All right, let's go ahead and get started. So my name is Emily. I'm one of the co-creators here at NCLEX Bootcamp. You're also going to see Courtney in the comments moderating. She was, you might recognize her from her webinar last week. And so she's going to be answering any questions that you guys have, as well as giving you information on our discount code, because you're all eligible for a 25% off discount for an NCLEX Bootcamp subscription just for being here today. So thank you for showing up, and I'm thrilled to be talking to you about what's on the Next Generation NCLEX. And so we're going to specifically look at the purpose of the NCLEX, the top 5 client need areas on the NCLEX, and then we're going to spend most of our time going through some live question practice of the number 1 client need area. And so first, we'll consider what is the purpose of the NCLEX. And how many of you guys leave a thumbs up if you've heard somebody say that the NCLEX is a safety exam? So how many of y'all have heard that said before, that the NCLEX is a safety exam? Okay, some of you. All right, yes, and that's because it really is ultimately true. At its core, the NCLEX is a safety exam, and that's because the goal of the NCLEX is to protect the public. And they do that by determining with a 95% confidence interval that you are going to be a safe entry-level nurse. And they define entry-level as a generalist nurse in the first 12 months of practice. So you are not going to see any sort of questions that are aimed for like a specialist nurse with a ton of experience. You're really just going to see things that are very safety focused. And so that's the kind of practice we want to give you here at NCLEX Bootcamp, is that really important stuff that you're very likely to see on the test. And so the way that they decide what goes into a safe entry-level nurse is with every 3 years conducting a practice analysis survey. So they ask practicing nurses, on your last shift that you worked, what are the things that you did most often, that are most important, and that require the most clinical judgment? And so the big one that comes out on top is, of course, just using your clinical judgment, monitoring your patients, making sure they're safe. And so that's what goes into the case studies. And then the other standalone items are made up of these client need areas. And even if you aren't familiar with these terms, you guys know what questions these are, right? So management of care is going to be your prioritization, delegation, assignment, safety infection control, that's your PPE and safety. Health promotion and maintenance, that's your normal growth and development, normal disease prevention, vaccines, etc. Psychosocial integrity is where you'll find your therapeutic communication items. Basic care and comfort, that's the stuff you learned in semester 1, right? Mobility, hygiene, skincare. Pharm, we know what's there. And then reduction of risk potential, so all the things that carry risk. Having a Foley carries a UTI risk. Having a central line carries a CAUTI risk, so preventing and reducing that risk. And then physiologic adaptation, this is kind of your catch-all for the nursing process for all the major disease processes and some OB complications. But we are going to be covering clinical judgment today as the big one that you see in your case studies. If you guys keep coming back to our webinars, you're eventually going to see us cover all of this content. We have just a prioritization and delegation focused assessment focused, as well as prioritization. So keep coming back, and if you guys remember, those top 5 client need areas make up about 70% of the exam, so a large portion of it. And the number 1, remember, clinical judgment, management of care, pharm and parenteral, and physiologic adaptation and safety and infection control. So again, you'll see all of these, and go ahead if you haven't already and invite your friends to keep coming back to the group so you can see all these topics covered as we go through them. All right, so in that 6-step clinical judgment process, this is outlining how a nurse thinks. And we're going to cover questions that cover each one of these 6 steps, but roughly this aligns with the nursing process. So you are going to see assessment of what's most important, diagnosis of figuring out what could it mean, and then planning, your care planning of what problem do I start with and what can I do to solve that problem, as well as what action can I take to address it and how do I know if that action helped. So remember, you're going to see these items on the NCLEX in the form of case studies, but just so we can go easily through it here today, we're going to look at standalone items that feature these clinical judgment thought processes, because that's going to still make up the bulk of your exam. So first, the ability to recognize cues is the ability to determine what is most important here. Because your patient is never going to have just one problem in isolation. They're going to have more like 10. And so we need to know that as a new grad nurse, you can choose what to ignore or wait to address and what you need to address right now. And so the first question we're going to look at asks us, while we're caring for a client with severe COPD, which of these findings require immediate follow-up? So we're looking for something we need to follow up on, something that is not normal. So an unexpected abnormal finding, because some abnormal findings are expected. So to figure out which of these is our unexpected abnormal, let's do a quick COPD review. And so in COPD, we've got either chronic bronchitis or emphysema. And what's happened is smoking over time has damaged the lining of these bronchioles, causing it to narrow and inflame and constrict, and that's going to prevent us from getting air in. And in emphysema, smoking has damaged the alveolar lining here, and now instead of when the client exhales this air exiting smoothly, instead the alveoli is just going to kind of collapse in on itself. And so now the air can't get out either. So we've got this chronic air trapping. And which of these findings would we not expect to see with that? So how about lower extremity edema? Why would you guys see lower extremity edema in COPD? Do you remember the name of that complication? Let me see if you guys can remember that name. All right, somebody thinks it's 2, option 2. Okay, so the name, if you see lower extremity edema, that might mean this client has heart failure. And the reason that that happens in COPD is because over time, that low blood oxygen level is going to cause the pulmonary arteries to constrict. That's going to raise the pressure in the lungs. And which side of the heart would that put strain on? Would the lungs put strain on the right side of the heart or the left side of the heart? I think you guys know this one if you want to leave a comment. Would this cause failure of the right side of the heart or the left side of the heart? And all right, a couple of you saying left side, all right. Who else thinks it's the left side? So which side of the heart pumps blood to the lungs? All right, so the left side of the heart pumps blood to the body, and that is typically the side of the heart that fails in other types of heart failure, but it is actually the right side of the heart that pumps blood to the lungs. So we would see right-sided heart failure if it was caused by COPD, and that's called cor pulmonale. So this might be an expected finding, but does that necessarily mean I need to immediately follow up on it? And some signs of heart failure might warrant immediate follow-up, right? We might need to follow up if we had signs of pulmonary edema, like severe crackles with hypoxemia, or maybe they've got frothy pink sputum or restlessness. But if they just have lower extremity edema, that would probably be caused by a left-sided heart failure or just backup of fluid into the body. So all I need to do for this is kind of prop their feet up. I'm not too worried about this one right now. Then paradoxical respirations. Do I need to immediately follow up on paradoxical respirations? Yes or no? Let me know what you think, you guys. So paradoxical respirations, remember, when we normally breathe in and out, our chest rises and falls. When somebody has got paradoxical respirations, they're opposite. So when they breathe in, they're sucking in that breath, and then they're pushing it out. And so this means that their work of breathing is really, really difficult, and they're wearing out and they're developing respiratory fatigue. So this is a warning sign of impending respiratory failure. And this is always a warning sign in any patient, whether it's on the NCLEX in an asthma patient, a COPD patient, you are always going to immediately follow up on this one. So I think it's this one, but let's consider our other two. Would you expect to see an increased hemoglobin level in COPD? What do you think? Yes or no? Increased hemoglobin level. So this might happen because remember, we've got chronic hypoxemia. So the blood levels of oxygen are always low, and the body says, hey, my tissues are not getting enough oxygen. Maybe if I just produce more red blood cells, then I can carry more oxygen to the body. So you are going to see polycythemia vera. That's an increase, a compensatory increase in the hemoglobin and hematocrit. So I might see this as a chronic change, but it's typically stable and there's not anything I need to do about it. So it's not this one. Then finally, a pulse oximetry reading of 88%. Do you guys remember what the normal pulse ox reading is in COPD? What is a normal pulse ox reading in COPD? I'm looking for a range. And so it is going to be, nobody knows it. It's going to be, okay, Shan says 90. Shan, welcome back. I'm so glad you're here again. So yes, it is going to be 88 to 92%. That is our normal pulse ox range. So 88% is fine. This is an expected finding. Even if the patient was on oxygen, I wouldn't even increase it for a pulse ox of 88%. There's nothing to do about this. So the only one I need to follow up on is this paradoxical respirations. And we're correct, very good. And you guys will see that actually only about 60%, so only a little bit more than half of our students in our question bank answered this correctly. So if you guys got this one right, then you know, or you're already ahead of the curve. Great. All right, so now that we figured out which cue is most important, we need to figure out what could that cue mean. And so here's an example of how they might ask that. If a client with we suspect they have chronic venous insufficiency, which finding would support that diagnosis? And the NCLEX loves to ask which would be a venous versus an arterial finding. So let's talk about that. So in peripheral arterial disease, this is where over time atherosclerosis has limited blood flow down the extremities. So we are going to see signs of arterial insufficiency, and this is where you'll see your 6 Ps, right? The leg is painful because it's starved for oxygen, it's pale because there's not enough blood flow, it's cold because there's not enough blood flow, and we might have diminished pulses. And then when you think about where your ulcers would be, with artery disease, I like to think of this as, well, the problem is where the blood has the hardest time getting. And the further down the leg, the more that blood flow is limited. So you're going to see ulcers in peripheral arterial disease show up on the most distal parts of the foot. You're going to see them on the toes, the feet, and maybe the shins. Versus in chronic venous insufficiency, where now we have a problem with blood return, not blood flow. So these valves fail, and instead of blood being moved up the leg back to the heart, it starts to pool in the lower extremities. So we're going to see signs of blood pooling. We're going to see edema, swelling. It's going to feel achy, heavy. And then our ulcers, because the problem is up higher on the leg, we're going to see them higher up. So we're going to see them on the ankles, the calves, and the lower extremities. All right, so which of these then would support a diagnosis of chronic venous insufficiency? An absent pedal pulse, is that an arterial or a venous problem? What do you guys think, arterial or venous? And I think you know that one. We can pull this back up. And yeah, so we have got an impaired blood flow to the limb. We're going to see diminished, weak pulses. So this would be more of an arterial problem. Good. Then intermittent cramping with exercise. Is that more arterial or venous? Okay, you guys got the last one right, arterial. And yeah, so intermittent leg cramping with exercise is also an arterial problem. Remember, that leg muscle is starved for oxygen, so when the patient's walking around and it uses up all the oxygen that's already there, more can't get through and they start to cramp. And we call that intermittent claudication. And that, yes, is an arterial finding, not a venous one. Good. How about ulcers on the toes with well-defined edges? Is that more characteristic of venous or arterial disease? Yes. Good. Arterial disease, because remember, with arterial disease, the problem is where the least blood flow can reach, and that's going to be the distal part of the foot, the toes. Good. So that leaves us with this brown discoloration to the lower extremities. And this is one of those signs of blood pooling. Because blood pools in the lower extremities, it can't escape back up to the heart, and so it kind of seeps into the surrounding tissues. And one of the major components of blood is iron, and iron can rust. That's how I like to think of this, is it's associated with a venous problem because the blood is just pooling there and kind of rusting as it sits there, stagnating. And so these are called hemosiderin deposits, and this is characteristic of venous insufficiency, which is what this item is asking us. So very good, and again, only about half of people got this correct. So if you guys got this one right, you're ahead of the curve. Well done. All right, so now we figured out what those cues can mean. We need to figure out, what do I start with? What do I prioritize? And before this next question, I want to ask you guys, if you have a patient who just came out of a craniotomy, what priority complication are you worried about? What is the big complication we're worried about with a post-craniotomy patient? And there are several, but specific to craniotomy. What do you think? Okay, Shan says bleeding. That's definitely something I'm worried about. Good, all right. Jules, you say increased ICP. Yes, good. We're worried about increased ICP, which, Shan, could be caused by bleeding into the head, and that would be how we know, is we would see signs of increased ICP. Good. So we're prioritizing an increased ICP. How do we prioritize monitoring for that? Because we're going to be doing a full neuroassessment, and we're going to be looking at all of these things, but only one of them is going to give me the most important, fastest information about their intracranial pressure. So would it be the Babinski reflex? And real quick, side note, if you stroke your patient's foot to assess the Babinski reflex, in an adult, is it normal for the toes to curl or to fan out? What would we see as a normal finding in an adult? Okay. All right, we would see in a baby, the toes would normally fan out, and we would see the toes curl in an adult normally. Good. All right, so the Babinski reflex is it's a useful part of our neuro exam, but it's really going to tell us more about the presence of any spinal cord injury more than it would ICP. So it's not this one. Presence of a headache. Would I see an increase in a headache pain or head pain after a surgery, craniotomy? Normally I would. It might just be normal, so it's not necessarily going to tell me that there's a complication, so it's not this one either. Pupil size and reactivity, is that going to change in increased ICP? Yes, it would, right? But that is going to be a late finding. If your patient's pupils are already fixed and dilated, that is a very late sign that their ICP has increased. And before you see that change, you are going to see a change in the level of consciousness. And this is a big NCLEX tip, you guys. Your level of consciousness, remember this, is your earliest and most sensitive indicator of any change in ICP. So if they say this client has become obtunded or has an altered mental status or is lethargic, that should immediately cue you in that I have got increased ICP developing. And good, very good. All right, so now that I know where do I start, I need to know what can I do about it? What actions will help address this problem? And so here we are taking action for a patient who just had a coronary angiography. And in a coronary angiography, what problem does this treat, you guys? Who would we be doing this to emergently if they came into the hospital? What would we be treating here? All right. What condition? Let me see. Good. Yes, so we would be doing a coronary angiography to treat narrowing in the arteries, specifically from coronary artery disease or an MI. And an MI, that is the endpoint of CAD. Someone comes in with chest pain, we're going to go cath them, and this is going to actually make a puncture into their femoral artery, thread this catheter up to the side of the blockage, and they're going to visualize this under x-ray while they inject a bunch of radiocontrast dye. That's going to help them locate where the blockage is, and then they're going to thread a stent in and balloon it open to restore that blood flow. So this is a very invasive procedure, and after they come back, we are most worried about several things, but primarily bleeding and complications from that heart muscle cell dying. So which of these interventions is important in that post-procedure care? And because this is a select all that apply, remember in a SATA, we treat each option as its own true or false. So let's do that here. True or false, after an angiography, do you want to place the client on a fluid restriction? Yes or no, true or false? Okay, ACE has thrown out some guesses for 2, 3, and 5. Okay, would we want to fluid restrict them or would you want to push fluids? And remember, one of the number one causes of renal failure in hospitalized patients is contrast nephropathy, is kidney failure from IV contrast. The kidneys hate this stuff. And so we want to give a lot of fluids to help flush it out. You do not want to fluid restrict them. So it's not number one. That is false. All right, do you want to monitor the puncture site for swelling? Definitely. If we've punctured the largest artery, one of the largest arteries in their body, we're worried about bleeding at that site, especially because right before we took them to cath lab, we had them chew an aspirin and gave them a bunch of heparin, right? So I'm going to monitor that site for swelling, which would indicate bleeding. Good. Why would I want to place them on cardiac monitoring? What complication would that tell me about? Good. You're saying true. Yes for this. Good. Yes. So obviously we just had some heart muscle die and it's inflaming, it's swelling. And so that can trigger some dysrhythmias, some lethal dysrhythmias. So I absolutely want them on continuous cardiac monitoring. Do I want to assist them up to the chair to prevent atelectasis? What do you think? In the initial post-procedure care. And so we do want to prevent atelectasis. We're always worried about the collapse of the alveoli when someone who's been, still for a long time or underwent any sort of procedure with sedation. But we cannot have these patients get up. We just punctured this femoral artery that's right where they would bend at the waist to stand. So they need to stay completely flat on complete bed rest, usually with this affected extremity restrained, if they can't remember to keep it straight, for 6 hours. And so that is a long time to stay completely still with your leg flat. And your patients will tend to complain about this, but we have to remind them how important it is to prevent bleeding. So we can maybe have them do some deep breathing exercises, but we cannot get them up to the chair. This one is false. All right, would we want to palpate their pedal pulses every 15 minutes for the first hour? Yes, definitely. Because remember, we're worried about bleeding. And so if that blood is coming out either internally, maybe into the patient's back, called a retroperitoneal bleed, or externally, forming swelling and a hematoma, either way, the blood is not going to be traveling down the leg, and we would feel that as a diminished pulse. So this is very important. Every 15 minutes for the first hour, then hourly for 4 hours. We are all the time going to be going into the room, warning your patient, pulling off their sheets, looking at that puncture site, and feeling their pulse down at the foot. So that's what we're going to do for someone after a coronary angiography. Very good. All right, so now that we've kind of planned what we can do, we need to actually do it. We need to take action safely. So here in this question, we review the diagnostic results for a client who's become unresponsive and has no palpable pulse. They've got gasping respirations. Which action do we take? So we're taking action. So here, let's look at our diagnostic results, and this is what we see. So what do you guys want to do? Drop which number of options here you think you want to do for this patient. What action are you going to take? Are you going to 1, initiate chest compressions, 2, give IV push atropine, 3, get a 12-lead EKG, or 4, deliver rescue breaths with a bag valve mask? And you guys want to do 1. Adriana, Karen, I definitely want you guys to be my nurses. I love that. Yes, we need to immediately initiate chest compressions for any patient who has no pulse. Whatever other findings we have, if they are not responsive, if they don't have a pulse, they're pulseless. If they still have some EKG activity that looks normal like this, don't be fooled, this is pulseless electrical activity, or PEA. This could look as pretty as we like, and it doesn't matter if it's not generating a pulse. So really the only information that you need here is this piece, no pulse. So don't forget that on the NCLEX. Pulseless patient, you have to do CPR because that's going to restore blood flow. So yes, it is this one, but why might we have thought it was these others? So atropine is going to treat bradycardia, right? And this rhythm is slow, but atropine would only be appropriate if it was a normal rhythm and we already had a pulse with it. That would speed up the pulsatile rhythm. But even if I speed this up, it's not producing a pulse now. Why would it produce a pulse at twice this rate, right? So this is not going to help. This is only going to help if they already had a pulse. Would we get an EKG? No, it doesn't matter. No matter what the EKG shows, if they don't have a pulse, we need to do CPR, and the EKG is just going to delay that. So that's not correct. Then delivering rescue breaths. Now, if you have somebody with gasping respirations or slow respirations, maybe in an opioid overdose, who still has a pulse, that would be all they would need, with some rescue breathing. But in someone who has no pulse, the only thing that we should focus on doing at first is initiating chest compressions. Good. And only about half of our students got this right. So you guys remember that. If your patient doesn't have a pulse, don't be afraid to start CPR. Great. So finally, after we've taken all of these steps, we need to evaluate outcomes and figure out, did it help? Did my interventions help? Did my teaching help them understand? And so that's what we're going to look at here is we have taught a client who's about to undergo a total laryngectomy, and we need to know which of these statements would require follow-up. So what do we need to correct them about? We're looking for an incorrect statement here that indicates they don't actually understand. So in a laryngectomy, remember, this is removal of the larynx, which is responsible for what? Creating what? What function is the larynx responsible for? I think you guys know this one. Voice box, yes. Shan again. Shan, you're killing it. Yes, absolutely. The larynx is the voice box. And so if we are taking out, that's ectomy, we are removing their voice box, there's a lot that goes into that. This is a big change for this patient. And so which statement by the client would require follow-up? Should they say, I will have to practice using a mirror to care for my stoma? Is that right? Do they have to? And yes, they do. This is a big body image change, and a lot of patients can be kind of grossed out by themselves. They don't want to look at it. They don't want to touch it and handle it. But it's important that we work with them to use a mirror, to visualize it, to practice carrying it and touching for it so that they can cope with that change in body image. Good. All right, when I'm discharged from the hospital, I won't need the feeding tube. So your larynx really isn't involved a whole lot in your swallowing. They should be able to swallow and eat normally after this surgery. It's not going to affect that. So no, they should be eating and drinking normally. It's neither of these. How about this one? My husband has bought me some scarves to wear loosely over the stoma. Is that okay? All right, you guys are all thinking it's 4. Yeah, so it is okay to wear a scarf. It might seem scary because it's covering it, but as long as it's loosely draped, which they say here, loosely draped, it's clean, it's not constricting, this is fine, and it can also help them cope, again, with that body image change. So this is okay as well. We don't need to follow up. So yes, you guys are right. It's number 4. After the surgery, my voice will be hoarse, but will eventually return to normal. That is not correct. That requires follow-up. We need to follow up and correct them and probably get the healthcare provider here to explain this procedure to them again before they can provide informed consent, because that is going to be the biggest risk after the surgery is they're going to lose their voice, and we need to make sure that their expectations are realistic before the surgery. So it's that good. Good job, you guys. So, all right, very good. You guys did so well today. And I want to know, do you have any questions before we sign off for the day? What questions can I answer for you, either about clinical judgment or the NCLEX? Anything you guys want to know, we can talk about it here while we have some time. Yes, amazing job, everybody. You all did so well. And this is just a very small sampling of some items that we have in our question bank. You guys can go play there and review all of our high-yield questions to prepare for the NCLEX. So, okay. I'm not seeing any questions come through for everybody, so all right. We'll sign off for the day. Please join us next week for our next Facebook Live, and thanks for coming out to this one, and don't forget to invite your friends so that we can all practice for the NCLEX together. Very well done. We'll take just a second longer to let some more people show up, and then we're going to get started. Couldn't have done it without this program. Well, you're very welcome. We're very, very happy to help. We're so excited that all of you are here. We love helping students pass the NCLEX, and yeah, hopefully, you're going to go on to be a better nurse because of it. Prabsamran, I hope I'm not saying your name wrong. Thank you. We love our rationales too, and thanks for joining. Very good. So, okay, we're going to go ahead and get started quickly. If you guys see me looking off the side of the screen here, I'm watching your comments separately. So, yes, I am Dr. Emily. I'm one of the co-creators here at NCLEX Bootcamp. We've got Dr. Amber in the chat moderating, going to be answering your questions. I'm going to be watching your comments as well. There might be a little bit of a delay. We're not ignoring you. We're going to try and get to everybody's questions by the end of the thing. But yes, thank you so much for joining us. We're so, so happy that you're here. And we're going to be talking about answering Next Gen case studies. So first, we're going to look at the NGN case study format, what it looks like, and then most of our time we're going to spend practicing going through a case together so that you guys can get that practice thinking like a nurse, which is really what we want to teach you here at NCLEX Bootcamp. So first, the case study format. So each case study on the NCLEX is going to have 6 questions that corresponds to each of these 6 steps of the clinical judgment measurement model. And you might not be familiar with this, but you've probably seen the nursing process before your ADPI. And this is really similar. This is essentially just the thought processes that we go through in every single patient encounter. And so that starts with recognizing cues or assessing out of everything that's going on what's most important here, analyzing those cues or considering what could it mean or what disease processes or diagnoses is that associated with, prioritizing hypotheses, so figuring out what we start with first, generating or planning what solutions or interventions we can take to address those problems, then actually taking those actions and evaluating if they helped. So we'll go through each of these steps in detail as we answer the case together, but this is ultimately how the case is laid out. And you are going to have 3 full-length case studies on a 85-question test. That means it's going to make up for 3 cases, 6 questions each, about 25% of your score. If you have a longer test than 85 questions, you're going to see additional clinical judgment items in the form of trend and Bowtie items. But either way, this is going to make up a big chunk of your test because this is really important. This is kind of the heart of nursing. The NCLEX is a safety exam, that is true, but it is also a clinical judgment exam starting with Next Gen, where we need to make sure that we can think like nurses to keep our patients safe. So we'll get some practice doing that together. So let's do it. Let's practice thinking like a nurse, and we're going to be walking through one of our cases together. And I want to know from you guys, how many of you were actually able to practice Next Gen cases in school? Like in your nursing program, let me know if you had some kind of school-provided Next Gen case study practice or if you had to go somewhere else to practice Next Gen cases. Because I think it's really hard to create these really well. And so we've got 50 case studies on our website for you to practice with. So Kier said, not me. Neither did Verona. So yeah, it's really kind of hard to come by good, solid Next Gen case study practice. So we're going to walk through this case today, but yeah, we've got 49 others on our website that you guys should definitely check out, and Amber's going to make sure the link to our stuff is down there for you. But yeah, this is basically what it looks like. The big difference in the Next Gen cases versus your standalone NCLEX items is you've got a lot more information. You guys might have heard that the NCLEX is vague, and that is true for the standalone items. You only really have enough information to answer the question, but that's not real life. In real practice, our patients never have just one problem in isolation. They never have just pneumonia, right? They have so many different things going on. Their chart is full of information, and we want to make sure as the first step that we can recognize cues or figure out what's most important here. So in the case, you'll be able to click through all your tabs just like you would in a real patient chart. And that when you are recognizing these cues, reading through these client data tabs, I want you guys to really practice every single time envisioning this scenario closely. Try and keep this mental picture in your mind of what's going on with the patient, and always kind of have in mind what you think your priority problem or priority problems are. So don't lose sight of that. Try and keep that in mind as you progress through the case. And then of course, at any point, if the case client data tabs update or you get new information, revisit that mental picture. There are things that can happen in these case study updates. You can move from the ER to the OR, or from the ICU to step down, or even be discharged home. And so make sure you have this mental picture of what's happening with the patient at each step in the case. So let's take a second envisioning this scenario closely. I'm going to kind of click through and highlight important things. Of course, on the real exam, you guys are going to have a whiteboard that you can use to kind of note anything that you think is really important to keep in mind. All right, so keep all this in mind. We've got this 57-year-old client. He comes to the emergency department feeling short of breath and having a cough for the last 2 days. He's been sleeping on 2 pillows, waking up coughing. He's felt very fatigued and spends most of the day in the bed or the chair. He appears anxious, and then he has got this long history of cardiovascular risk factors: hypertension, hyperlipidemia, chronic stable angina, type 2 diabetes, and he's worried that he can't afford his medications. So reminding you guys to keep this mental picture in mind as we move on. This relatively young gentleman is short of breath, he's coughing, he's anxious about it, he's sitting upright. Keep that mental picture in mind and add to it as we continue reading, all right? So in our assessment, we see he's oriented, that's good. He's got crackles in his lungs. He has an S1, S2, and an extra S3 heart sound. His bowel sounds, cap refill, and pulses are all normal. And then he's got 1+ pitting edema to his lower extremities. So on top of this picture of shortness of breath, staying upright, he's also got edema, an extra heart sound, and crackles. Keep all this in mind. Then we look at our vitals. We see that he's afebrile, he's a little tachycardic, little tachypnic, little hypertensive, and then our pulse oximetry reading is low. So keep all this mental picture. And I want to ask you guys, I kind of see two priority problems here, two big things that are happening. What would you guys say your priority problem is? Drop it in the chat, what you think is kind of the priority thing that's going on. Because I think there are two, and I think we all see the first one is maybe the shortness of breath, right? He can't breathe. We don't need to overcomplicate it. He can't breathe. He's having a hard time breathing. We've got the dyspnea, the low pulse oximetry. What might your other problem be, your second priority problem? So in addition to these respiratory findings, what other things are you guys seeing here? What other problem? Yes, Jackie, the shortness of breath, definitely. That respiratory insufficiency is, I think, a big one. Shan says the crackles, definitely. So we've got these other signs that really make it seem like maybe he has too much fluid on him, right? We've got swollen lower extremities. The extra heart sound, the S3, is always going to indicate fluid overload, right? So we've got somebody who's short of breath with some fluid overload. So keep this mental picture and those two priority problems in mind. So, all right. Now we want to consider what's most important here. You saw there was a lot happening, but there are only a couple things that are most important. And the NCLEX might ask you that as what requires immediate follow-up or which 2, 3, or 4 findings are most concerning. So as we consider that, try and figure out what are our unexpected abnormals that we're looking for. And if you're being asked about how to follow up and you're not sure, always kind of have in mind how you would follow up. What would it look like if I was going to select this option and follow up on that? So let's keep that in mind. So of these findings, we want to select the top 4 that require immediate follow-up. So we're looking for unexpected abnormals that we can do something about. And keep in mind that for a select N, so if you're told to select 2, select 3, select 4, you always want to select the maximum number possible because you won't lose points for selecting an extra option, if that makes sense. So in a regular SATA, only select the ones you're sure of. If you're being asked to select a certain number, always select that full number. Never leave one off, all right? So let's go through, and we're only gonna select at first the ones that we are 100% sure require immediate follow-up and nothing could convince us otherwise. So let's take these one at a time. What do you guys think for cough? Do you think that we need to immediately follow up on the cough, yes or no? Is that something that requires immediate follow-up? So when I think, is this an issue of airway, breathing, circulation? It might be related to a respiratory problem, right? Maybe an upper respiratory tract infection, but Shan, I agree with you. Shan says no, and I agree. We really don't want to follow up on that cough right now. There's nothing that I would do about this right now. So great, the edema. So what do you guys think? Is the edema something that I want to follow up on immediately? Because it is potentially an issue of circulation, right? But, okay, Shan thinks yes. I'm not so sure, because if I know that one of my issues is he's having trouble breathing, he can't breathe, I'm probably going to hang on for some respiratory findings first. But I'm going to keep this in mind. This might be a good priority issue. Crackles. Okay, Jackie says crackles. Yes, I agree with you. So yes, when you hear crackles, that means something is happening in the lung that's interfering with gas exchange. And we have evidence of that, right? We've got a low pulse oximetry reading. So these crackles tell me something's happening that's impairing his respiratory status. Good. How about the respirations? Do you guys want to address those immediately? Yes. Mariana Courtney says, yes, I agree. That tachypnea is compensatory, right? If you've got a low pulse oximetry, which hypoxemia is our next option here, then your body's going to compensate by increasing that respiratory rate to try and get more oxygen delivered into your lungs because it's not picking up enough and carrying enough. Good. All right, so we've got 3 so far. Is blood pressure our 4th? What do you guys think? Do we need to immediately follow up on this blood pressure? So Shan says, no. Shan, you're killing it today with these. I agree with you. So I'll ask you this about the blood pressure. Is it expected or unexpected for this client? This blood pressure of 149/93. Expected or unexpected? So I'm going to point out here, this guy's got a history of hypertension, right? So he not only has high blood pressure, but he's also told us that he's been concerned about affording his medications. Maybe he hasn't been taking them. So this might just be his everyday blood pressure. Yes, I agree with you guys. I think this is expected. If he had some unexpected signs of high blood pressure, like a really severe headache, or blurred vision or mental status changes, then I might prioritize that, but he doesn't. I think this is expected and we can ignore it. Good. Shortness of breath. What do y'all think? I think you guys know what to do with this one. Should we follow up on the shortness of breath? And yes, definitely. So that is part of our big picture, respiratory insufficiency, but let's consider our last 2 options just to be sure. How about his inability to afford medications? Well, there's nothing really I can do, even though it is obviously very important that we get our patients access to their medications and their care. That's not something I'm going to immediately follow up on as a psychosocial issue. I'm not going to call the social worker in here while he is sitting up, breathing hard, fast with a low pulse oximetry. Same thing with a history of chronic stable angina. How would I follow up on that? Just like ask him things about his history, how well it's controlled. There's really nothing for me to do about this. It is going to help us inform what might be causing his symptoms, but it is not higher priority than these signs of respiratory insufficiency, or crackles, tachypnea, hypoxemia, and shortness of breath. And we're correct. Well done, you guys. And so average score on this was only 1 out of these 4. So you guys who got all 4 are way ahead of the curve. Well done. All right, so our next question in CJM cases is going to be analyzing cues, or then figuring out what could it mean. And the NCLEX might ask you what conditions the client's experiencing or at risk for experiencing, what disease processes could cause these findings we're seeing, or how would you know if X or Y disease was happening. So keep in mind the big picture. We've considered in the previous questions the individual findings. Now you want to think about the big picture and specifically consider some specific versus non-specific findings. And shortness of breath is a very common non-specific finding. It could mean 100 different things. So I want you guys to drop in the chat, what are anything that you can think of that would cause shortness of breath? Because there's just so many things. I'll start naming a couple with you. I think we have the obvious. If we start ABCs, we could have any kind of airway issue, right? Maybe smoke inhalation, or in a child, like an epiglottitis. Breathing issues, so Shan says asthma, definitely. Miriam says COPD, for sure. These can cause breathing issues. Maybe pneumonia. Yep, Brianna got it, pneumonia. How about some circulation issues? Are there any circulation issues that can cause shortness of breath? Okay, AK says CHF. Yes. Cardiac problems, Mariana. Very good. What about something like anemia, right? We don't have enough oxygen carrying capacity in our blood. Maybe a pulmonary embolism. We can't get blood flow to the lungs. So you can kind of see there are so many different things that can cause shortness of breath, and it's not a very specific finding. But then we do have some specific findings that might be associated with it. So for example, think about a patient who has shortness of breath and we think it's pneumonia. What other signs and symptoms that patient had might make us think it's pneumonia? Like, what other findings apart from the shortness of breath would point you toward pneumonia? Think like vital signs, lab values, symptoms. What are some specific findings? Fever, definitely. AK's got it. Yeah. Fever,
White blood cell count might be elevated. Maybe they've got a productive cough, so they're coughing up yellow-green sputum. So if our non-specific finding is shortness of breath, our specific finding might be the fever, the sputum, the white blood cell count. So we want to consider the big picture here as we go in to analyze these cues. And we need to figure out that crackles throughout the lungs in this client are due to either infective infiltrate, collapsed alveoli, or fluid accumulation related to either pneumonia, heart failure, or reduced mobility. So crackles is what we're thinking about here. And any of these things could cause crackles, right? Have you guys had an opportunity to actually listen and auscultate crackles in your clinical sites? Or maybe if you're already working somewhere, have you had a chance to hear this before? Sounds kind of cool. It's described as like that snap, crackle, pop sound. And if you've never heard this in your patient, you can actually just take, so Shan hasn't heard it, you can grab a little piece of your hair and kind of roll it back and forth between your fingers, and it creates that kind of snap, crackle, pop noise, and that's what crackles sound like. And so this is described to me as, think of it like you're blowing bubbles through a straw is what you're hearing. You're hearing air passing through fluid, or if alveoli collapse, they can kind of pop open in the inspiration. So any of these things can cause crackles. And in this client, do you guys think that these crackles are due to an infective infiltrate? Yes or no? So infective infiltrate is just a fancy word for pus, right? If we've got pus, infectious material in the lung, obstructing the airflow, which condition would infective infiltrate be related to, you think? Pneumonia, heart failure, or reduced mobility? Good, you guys are saying no. I agree, I don't think so either. So of these conditions, we talked about pneumonia being the infectious one, right? So I don't think it's that in this client. I agree with you guys. Now, how about collapsed alveoli? Which of these conditions would cause alveoli to collapse? Okay. Pneumonia might cause the alveoli to collapse, but you guys remember after a patient has surgery or when they're really immobile, for example, this guy's been spending most of the day in the bed or the chair, they can start to have atelectasis. So although he's at risk for this, if you ever hear crackles, if you ever hear that snap, crackle, pop in your patient's lungs, you can ask them to cough, and that's going to clear those. So if your crackles clear with coughing, say that 3 times fast, then you know that they were probably due to atelectasis. And this guy's been coughing for 2 days. He's been coughing all night. So I would have expected these crackles to clear if they were due to atelectasis. So then that leaves us with fluid accumulation, which you guys all, I think, want to pick and have pointed out that's related to heart failure. So how would crackles cause, or how would fluid accumulation cause crackles in heart failure? Let's talk about that. So in heart failure, there are 2 major risk factors that would strain your heart muscle. So the 2 big ones are high blood pressure, which our client has, and coronary artery disease, a lack of blood flow to the heart. So if you have high blood pressure, that heart's gonna have to work harder to pump. If you have a lack of blood flow to the heart, it's not getting enough oxygen supplied to it to pump. So those result in this ventricular dysfunction where the heart doesn't have enough squeeze. It can't squeeze blood forward, and so instead that fluid can back up into your lungs, filling the alveoli, and cause that blowing bubbles through a straw kind of sound when you listen to it. So yes, I think that that is our correct answer, and we're correct. Well done. Again, only about half the people got this, so you guys are doing a great job. So next, after analyzing cues, we want to prioritize hypotheses or consider where do I start? And the NCLEX for this might ask you, what is the client most likely experiencing? What are they at highest risk for, or what do you need to do first? And when we're talking about prioritizing, I always like to kind of keep this question in the back of my mind of, if I can only do one thing for my patient and walk away, what should that one thing be? All right, so we are going to prioritize hypotheses here, and we're being asked about risk. So this client is at highest risk for developing either respiratory failure, acute kidney injury, sepsis, or pulmonary embolism, and we can pick 2. So our 2 biggest risk factors. What do you guys think might be one of them? I think as we start top to bottom, do you think this client is at risk for respiratory failure, and that's going to be one of our 2 highest risks. So yeah, Shan says yes, and I agree. Remember, that was our number 1 priority issue we identified from the beginning, and we want to keep that picture in mind. This guy can't breathe. Of course, we're worried about respiratory failure. He's got low pulse oximetry. He's hypoxemic. I'm definitely worried about that. How about acute kidney injury? How would heart failure cause acute kidney injury? Okay, you guys are saying yes. All right, so let's think about this. Acute kidney injury is a form of organ failure, right? And whenever you've got this ventricular dysfunction, not only is that blood not being pumped forward and backing up into the lungs, but because it's not being pumped forward, it's not reaching the organs either as well. And so your kidneys depend on 25% of your cardiac output. Every milliliter of blood that leaves your heart, 25% of those go to the kidneys. And so your kidneys are going to be affected first if you have a decrease in cardiac output, and you can start to have this reduced end organ perfusion and organ failure. So definitely, I'm worried about acute kidney injury. I don't know if it's one of my top 2 yet though, so let's put a pin in that. So sepsis, what kinds of things put clients at risk for sepsis? What condition would put this guy at risk for sepsis? So if sepsis is an infection of the bloodstream, right, you would have to have an infection somewhere else first. So maybe a pneumonia or some other infection. We've already pointed out we don't have any evidence of infection. We don't have a fever, we don't have purulent sputum, so this is unlikely. How about a PE? I think I saw somebody say that at some point. What puts someone at risk for a PE? What other disease process? Because a PE starts usually where? In the legs, right? Good, very good. So, for sure, I don't think he has a PE or a DVT right now because we have pitting edema in both lower extremities. If we had it in just one lower extremity, that might make us think he has a DVT, which would be a risk for a PE. So, although he is at risk for all of these things, he's been immobile, so he's at risk for a DVT. He obviously is hospitalized or going to be, so he's at risk for infection just because we're touching him. But of the ones that we saw, yes, the respiratory failure and the acute kidney injury, or really any form of organ failure, are the 2 big ones. And we are correct. Well done. So all right, our next step is going to be generating solutions, or after identifying this priority problem, we need to figure out what can I do about it. So the NCLEX might ask which interventions are indicated or not indicated, which are going to address that priority problem, or which could worsen the priority problem. And so I want to point out here that this depends on your understanding of the content, because the same symptom we could treat 2 different ways if it's from 2 different disease processes. So how would you guys treat shortness of breath from pneumonia? What medication would you give? So to treat any sort of infection, we would need to give antibiotics, right? Versus shortness of breath from a pulmonary embolism. What medication would you give for that? Okay, Jackie says furosemide might be, all right, albuterol. So yeah, the furosemide for fluid, albuterol for bronchoconstriction. I was thinking antibiotics for pneumonia, or heparin for a PE, right? So same symptom, 4 different treatments. So you guys got to understand the content, and that's why we're talking about heart failure in detail. So now that we need to actually generate solutions, let's consider each one of these. Do we need to get blood for a blood culture? Is there any reason that we have to want to get a blood culture for this guy? So that would be indicated for someone who we do think has an infection, right? If they have the fever, if they have the purulent sputum, same thing, sputum for culture. We don't even know that his cough is productive. That is not anticipated, so I'm not going to select these. Then preparing for an echocardiogram. Does this gentleman need an echocardiogram? What do you guys think? What do you think about if he should get an echo? Okay, I can't tell if our no's are from the previous option or not, but Shan says yes. Shan, you should come to our webinars every week. But yes, I definitely want to get an echo, because in an echo, they're able to actually visualize the heart. They do this at the bedside, and we can see how much blood is being pumped out of the heart with each beat, and that tells us about the cardiac output, and heart failure is a problem of cardiac output. So I definitely want to do the echo. What about serum renal function tests? Do we need to do those? Okay, Sabrina says yes. Carmela says yes. Yes. Not only do we want to check for the acute kidney injury that we're worried about, but we also might be giving a medication that we need to check the renal function for. What medication do you guys might want to give this guy soon that we need to know his kidneys are functioning for first before we give it? This is a big NCLEX test thing, so make sure you know this. What medication would we want to look at his renal function for? It's going to be the Lasix, right? The furosemide. Our loop diuretics are nephrotoxic, so we don't want to give him the loop diuretic until we know that his kidneys can tolerate it and that he's not in renal failure. So I definitely want to do this. Oxygen. Does he need oxygen? Yes, I think you guys know that. If his pulse oximetry reading is under 90%, he needs oxygen. So we are going to give him some oxygen to titrate to keep his pulse ox greater than 90 to 94%. Do we need to get a 12-lead ECG? Do we need to hook some stickers up to this guy and see what his heart rhythm is doing? Okay, you guys are saying yes. Yes, because we don't know if his heart failure could be caused by maybe a heart attack or atrial fibrillation. He does have all of the risk factors for a myocardial infarction, and myocardial infarction is the #1 cause of cardiogenic shock, which is an extreme form of heart failure. So definitely I want to get a 12-lead EKG and make sure his heart is not failing because the muscle is dying, basically. Then draw serum B-type natriuretic peptide. Do we need to get this? Do we need to get a B-type? Yes, Michelle says yes, for sure. Because the BNP is released when your ventricles stretch. So if we have a high BNP in the blood, that tells us that those ventricles are being stretched from fluid overload. And it tells us about the severity of heart failure. So yes, these are the things I want to do for this guy right now. Get him some oxygen and then do a quick workup with an echo to visualize his cardiac output. Make sure his kidneys are doing okay before we give him any Lasix. Get the 12-lead EKG, make sure he's not having an MI, and then get the BNP to diagnose the severity of the heart failure. And we're correct. Very good. All right, so next we need to look at taking action, or what will I do? Should I do it? How do I do it? The NCLEX wants to know that you can safely do the thing, right? And so here we're being asked to prioritize after diagnosing with heart failure and getting our lab results that show a low sodium, low normal potassium, and an elevated BNP. So we need to consider which of these orders should the nurse prioritize. And before we talk about this question, let's talk about prioritization. How many of you came to Dr. Amber's lecture on prioritization a couple weeks ago? Because it seems like a couple of you guys have been coming back for these. And we love when you join us each week. Tune in for these webinars. Be sure in the group before you guys leave today to invite your friends so that they can also come. See, Shan, you missed it. I'm sorry a friend didn't invite you. Sabrina came. Good. So yes, we want to make sure that you guys are all invited and getting notified when we're having these. So please invite your friend to the groups. We're really loving the community that you guys are creating here. So from her prioritization lecture, just to give you a quick little recap, obviously first we're going to eliminate any stable chronic issues because those are expected abnormals and not our priority. And then from there, we're going to prioritize first issues of airway and safety. The NCLEX is never going to ask you to prioritize between an airway and a safety issue. That would be too hard. So airway or safety, and then from there, your issues of breathing, circulation, or disability, which is neuro symptoms, maybe like things that would make you worry for hypoglycemia or a mental status change or stroke. And then of course, everything else routine is our lowest priority. So here, which of these orders should we prioritize for this client with heart failure? Either preparing for a chest x-ray, giving enalapril, giving furosemide, or preparing for an echo. What do you guys think? Let me take a look at, I think a couple of you already said, okay, a couple of you already said you think 3. AK thinks it's 3. All right. So I'm going to ask you guys, do you remember the kind of NCLEX strategy of always assessing first? How many of you guys have heard that before? That in a priority question, you always want to pick the one that's assessment first. I know you've heard that. That's so common, right? And here I'm going to point out, we've got 2 assessment actions. We've got prepare for chest x-ray, prepare for echocardiogram. Those are forms of assessment. But do we need a chest x-ray or an echocardiogram to know that this patient has trouble breathing and fluid overload? No, sometimes additional assessment is not necessary, and this is one of those cases. So you've got to know the content. You can't get caught up in just test-taking tips, right? So between our meds, enalapril and furosemide, those of you who said furosemide, that you want to do that one first, why is that the one that you'd pick over enalapril? Because furosemide is what? What class of medication is this? It's a loop diuretic. So we want to make sure that we get that fluid off. That fluid, that pulmonary edema is what's creating all of these issues breathing. So we want to do that first. Exactly. Good, you guys are doing great. Excellent. So next, we want to know finally, did it help? We want to evaluate, was it effective? Whether that was our intervention or our teaching. Was our teaching effective? Or maybe what signs would tell us a complication has developed? So let's look at that here. We have we're being discharged on enalapril, metoprolol, furosemide. We've taught the client, and we need to figure out which statements indicate the teaching was effective. And because this is a select all that apply, we're going to treat each option like its own true or false, okay? So true or false that this indicates teaching was effective. It's best if I take my furosemide first thing in the morning when I wake up. True or false? What do you guys think? So you might have heard the sort of mnemonic for furosemide, which is LASIX, that it lasts 6. So it's got a duration of action of about 6 hours. That means if you give that furosemide at night before bed, your patient is going to be up all night peeing, and you are never going to get to sit down at the nurse's station. No, this needs to be given in the morning so that it does not interfere with their sleep. So this is effective teaching. Good. I should avoid eating prepackaged foods and over-seasoning my food with salt. Is that true or false? So yes, got a couple truths. Very good, because a lot of patients think that it's sufficient just to take the salt shaker off the table, but actually most of the sodium that we eat comes from packaged, canned, boxed foods. So that is true. We want to tell them to avoid prepackaged foods. Then I should contact my healthcare provider if I gain more than 3 to 5 pounds or 2.3 kilos in a week. Is that true or false? Yes, Catherine says yes. I agree, because you can't really gain fat that quickly if you have weight gain that rapid in a heart failure patient. That tells you that they are going into fluid overload and they're at risk for decompensation and being admitted to the hospital. How about this next one? It is important to weigh myself weekly to ensure that I'm not retaining too much fluid. Is that true or false? Should patients with heart failure weigh themselves weekly? How often should heart failure patients weigh themselves? It's daily, right? Because if we only weigh once a week, it could be too late. This can happen very fast. David, you said here, where sodium goes, so does water. That's very true. All it takes is a couple days of eating too much salt and non-compliance to cause a lot of fluid overload. We don't want to weigh weekly. Jackie's correct. That has to be daily weights. And they even have these fancy scales now that like communicate with an app on your phone or communicate with your healthcare provider's office so they can see your trends of weight. So yes, we want to weigh ourselves every morning, first thing in the morning, after using the bathroom, with no clothes on, or wearing the same clothes on the same scale, same time, right? So weekly is not enough. This is not correct. Then certain over-the-counter medications, and this might be cut off for y'all, like antacids, can contain high amounts of sodium. Is that true or false? Yeah, that's true. Medications, especially antacids, are really problematic. You think the NCLEX is going to test you only about these really dangerous medications, but a lot of people take antacids and don't realize that they've got a lot of magnesium in them, which is bad for kidney issues, or a lot of sodium in them, which is bad for heart failure and hypertension. So this is correct as well. And we're correct. So well done, you guys. I think you did a great job. Please check us out here on our socials. Remember to invite your friends, but I want to take a second and answer any questions that you guys might have. And hopefully you found this helpful. So what questions might you guys have about everything we covered here today? course, Amber's going to be dropping any important links for you. You guys can go check out our study schedule. You can go watch case walkthroughs like this on our other 49 cases. It's not just me, but our other experts in different subject areas, so pediatrics, psychiatric, maternal, and so on. And so, good. Okay, so Kears wants to know what's a good percentage to be at for NCLEX. So the NCLEX doesn't quite work like other tests where you need to aim for a certain percentage of questions correctly. You really only need to demonstrate that you're above the passing level. So theoretically, you could miss up to 50% of the questions on the NCLEX and still pass. But if you are using NCLEX Bootcamp to study, our NCLEX target is 61%, and you can see that on your performance page. So, and I'll show you guys what that looks like. So if you're using NCLEX Bootcamp to study, then you will actually be able to view your performance page here. And if you meet these two targets, so you answer at least 1238 of our questions and score 61% or higher, you will go on to have a 99% chance of passing the NCLEX. So that's a good goal to start with for a percentage to be at NCLEX. Sabrina, I'm so glad you found our rationales are awesome. So another prioritization question. Shan, we're going to be repeating our webinars every 2 months or so. We're going to keep them on a 2-month circuit. So keep coming back and keep inviting your friends, please, to join us here so that we can all study together. So Remya, I'm so glad that you enjoy boot camp. Brian, we're going to have some farm sessions coming.
All right, for those of you, like I said, who don't know me, my name is Courtney. I have been a nurse for 15 years, which is really hard to believe. And I've been a nurse practitioner in psychiatry for the last 7. So I'm one of the content creators and writers here at Bootcamp. And so we're going to do some practice questions today. And we have Amber, who is in our, who's our moderator today. Amber has been an emergency room nurse for a lot of her career. So she has been doing all the things that I would find way too incredibly stressful to do. So she's in our comment section. So if you have any questions along the way, or if you just want to pop in and say hi to her, I'm sure she would love that as well. There is sometimes a good 30-second delay or so when you put those comments in. So if she doesn't get to you right away, don't worry, she's going to get to it, but sometimes there's just a little bit of a delay. All right, and it sounds like everybody can hear me pretty well now, yeah? Okay. All right, so today we are going to be going through some single best questions or single best answer option questions, and we are focusing on these because you are really likely to see this item type on the NCLEX. So we're going to cover a wide variety of them to kind of get you feeling comfy with a lot of different topics. But before we jump into those practice questions, we're just going to cover really briefly how those item types are scored, and then we're going to talk a little strategy for how to approach those item types, and then we're going to do some practice questions together. All right, so for our single best multiple choice questions, these are scored very simply. There's nothing complicated or fancy about this. If you get the answer option correct, you'll get 1 point. If you get the answer option incorrect, you'll get 0 points. So nothing fancy or complicated, pretty easy to score. All right, so how should we approach a single best question? How do we think about these like a nurse? So if I could give you one piece of advice, my biggest piece of advice to you would be make sure you read that header and stem very, very carefully, because I have been guilty of this myself, where I've not read that header and stem carefully, and even though I know the question content, I've gotten the answer wrong because I've misread what it's asking. So let me give you an example. You might get a question that asks, which of the following actions should the nurse take? So in that case, it's asking you to identify a correct answer option. You might get a different stem that says, which of the following would cause the nurse to intervene, which means you're looking for an incorrect action or task. And they might even throw another curveball at you and say, which of the following actions should the nurse take first, which means that all your answer options are going to be correct, but we're just looking for the one that the nurse should do first. So you can see how reading that header and stem really carefully is very important. So that's my biggest piece of advice to you. But after that, as I'm reading through the question, I like to ask myself, what do I already know about this topic? So say I'm reading a pharmacology question and it asks me about an SSRI, like fluoxetine. I like to sit and think for a second about, what do I know about this medication? Are there any common side effects? Are there any really serious side effects that I need to know about? Is there anything I need to know about administration? So I kind of brain dump this all first. And the reason I do that is because it helps keep these things really clear in my head. Because say I start reading my answer options and it asks me, or it's giving me an option about a tricyclic antidepressant. And I think, oh yeah, that's correct for a tricyclic antidepressant. And I might get kind of lost in the weeds. But this question isn't asking me about tricyclics, it's asking me about SSRIs. So by brain dumping all that information down first, I can make sure that I stay on track and keep everything clear in my head. And then from there, I start diving in and I start ruling out my answer options. So, should we put this to the test? Should we answer some questions together? All right. So we've got a total of 5 today. This first one is going to be a prioritization question. And if you attended our webinar last week with Dr. Amber, this item type should look really familiar to you. She gave a fantastic presentation on prioritization. And so if you didn't get a chance to see that, I would highly recommend that you go back. It's saved on our Facebook page, so you can still watch it. But she gave a lot of really great tips for answering these types of questions. But we'll go through some of it again today. So let's answer this question together. So I'm going to be asking a lot of questions to you all, so make sure that you comment in the comments and let me know what you're thinking so we can all kind of solve this together. Okay, so in this question, we have an emergency room nurse who has received change of shift report on the following clients. Which of these should the nurse see first? So this is a prioritization question. So of course, we're going to see all of these clients, but we need to identify which one we need to see first. And so the NCLEX, remember, is a safety exam. So when they're asking us who we want to see first, what they're asking is who is at the most imminent risk for harm, or who is in the most danger of having adverse health consequences if we don't see them right away. So we need to keep that in mind. So before we read our answer options, let's take a look at our prioritization table. And you probably saw this last week if you were on that webinar, but we're going to go through it again because this is a really helpful tool that we have to help us solve these types of questions. So the first thing we're going to do is we're going to eliminate any stable or chronic issues. So the example that always comes to mind for me with this one is, say we have a client with heart failure and they're having dyspnea on exertion. Well, we know that dyspnea on exertion is an expected finding for a client who's experiencing heart failure. There's been no acute changes. This is a chronic condition. This is probably going to go on for a long time, right? So nothing's really going to change. There's not going to be any harm. That's probably going to happen if we don't see this client in the next 5 or 10 minutes or even sooner, right? They're pretty stable. So from there, I'm going to go over and I'm going to start working my way from the top of this pyramid down to the bottom. So we have some more lower priority tasks on the top. So these are going to be routine tasks, more expected findings, and psychosocial needs. And here's an NCLEX tip for you, is we often see these psychosocial needs used as distractors. So that might be someone who's lost a job, or they're having relationship issues. And it's not that we're saying that these aren't important. Of course, we're going to address them at some point, but just because someone lost a job or they're having a relationship issue, that's not a life-threatening concern, right? It's distressing, but it's not life-threatening. So we're going to rate those as a lower priority than issues that are potentially life-threatening. So from there, we're looking for any neurological disability, any issues with breathing or circulation. And at the bottom, our most important, or our highest priority patients are going to be anyone with an airway issue or a safety issue. And this makes a lot of sense, right? Because if someone has an obstructed airway, if they're not getting oxygen, how long do we have to intervene before this becomes life-threatening? Probably seconds, right? We have seconds to intervene. So that's going to be our highest priority. And then safety, that's going to refer to any imminent safety concerns. So say we have a client with a weapon who's threatening to harm themselves. That's an imminent safety concern that's posing a very real risk to their safety. So with all of that in mind, let's go back to our question and see if we can use what we've just talked about to figure out who we need to see first. So our first option is this 7-year-old who fell out of a tree and is cradling a discolored and swollen arm. excuse me, what do you think is happening here? Discolored and swollen arm, they fell out of a tree. Does anybody want to venture a guess as to what might be happening here? I'm kind of thinking a sprain, a strain, maybe a fracture. But does this have anything to do with airway, breathing, circulation? No, it's a pretty localized injury, right? And we don't have anything to indicate that there's anything else going on in their body that would present an imminent risk of harm. So I'm thinking that's probably not our first priority. Yeah, it looks like you guys agree. All right, so let's take a look at our second option. We have a 3-year-old who's been vomiting for 12 hours and has a temperature of 103.6 degrees Fahrenheit. What do we think about this? If someone's been vomiting for 12 hours, especially a child, what are we worried about? I'm a little concerned about dehydration. And dehydration could present, what? A circulatory issue, right? Yeah, you guys got it. So this is going to be in our yellow zone of our pyramid, right? All right, so definitely a higher priority than number 1, so we can rule that one out, but let's see if we can find anything that's a higher priority than a potential circulatory issue. So our third option is an 18-month-old who is vomiting and was found with an open bottle of drain cleaner. So if they're vomiting and they have an open bottle of drain cleaner, it sounds like they've ingested drain cleaner, right? And what do we know about drain cleaner? It's corrosive, it's going to cause tissue damage, it's going to cause tissue irritation. And if they've swallowed it, it's going to cause tissue irritation and tissue damage in their esophagus. And what's right next to our esophagus? Does anybody know? What are you thinking? I am pretty concerned about an airway issue because if we have tissue irritation and swelling in the esophagus, that is going to close off our airway, right? So we have an airway concern. And remember, that was in the bottom of our pyramid in the red zone. So far, this is our highest priority, right? So let's take a look at number 4, just because, of course, we want to read all of our answer options to make sure that we haven't missed anything. We have a 5-year-old with epilepsy who experienced a seizure 30 minutes ago that lasted 3 minutes. Okay, so this child had a seizure 30 minutes ago, and we're not being told that there's anything happening right now. And of course, big NCLEX tip, we don't want to add anything to the question that's not there. So there's nothing really happening right now, it sounds like, that we need to address immediately. And even if we did, a seizure would be one of those neurological deficits, we could categorize it as, and that would be in our yellow zone, right? So the only one we have in our red zone is option number 3, and it sounds like a lot of you agree with this, right? Because this is an airway issue. So should we check and see if we're correct? I think we probably are. Yes, we are correct. Good job. All right. Okay, so let's move on to question number 2. So this is going to be a pharmacology question. And so we have a client who has hypertension and is taking lisinopril. And we're being asked which of the client findings are most concerning. And so this is another prioritization type question, right? So we could technically say all of these findings are concerning, but we need to figure out which one is most concerning. So again, think most concerning, which one of these is at, or which one of these findings is most likely to cause a safety issue or a threat to their life. So let's think about what we know about lisinopril. What type of medication is this? This is an ACE inhibitor, right? And we use this to lower blood pressure. What are some common side effects of ACE inhibitors? Does anybody know? I always think of that chronic cough that comes with these medications. That's a common side effect, not necessarily life-threatening, right? And what do we know about all blood pressure medications? They can cause what? Orthostatic hypotension, right? So we need to educate people to be standing up slowly when they're on these meds. What about real severe side effects that we need to keep an eye out for? I think a lot of you have said it already. I see a lot of angioedema floating around in those comments. You guys know your stuff. All right, so we already know quite a bit about ACE inhibitors already, so let's use that and see if we can figure out which one of these is most concerning. I already see a lot of you commenting number 1. So what might an itchy lips and tongue mean? Well, we talked about angioedema, and what is that? That's when the face swells up, right? The lips, the tongue swells up, and that could possibly be an airway obstruction, right? So that has me thinking they may be developing angioedema. And we know from our last question that if there is an airway obstruction, that's always going to take priority. So that would be very concerning. But of course, we want to read all of our answer options, right? So let's see if we can find anything that might be more concerning than that. We have a persistent dry cough. What do you guys think about that? Well, we already talked about that. That was a pretty common side effect, right? So that's not most concerning, right? That's kind of a common side effect. That's not really life-threatening. Our third option is blood pressure of 142/92. What do you guys think? It's a little bit high, right? It's not high enough to be a hypertensive crisis. So this tells me that their blood pressure medication really isn't doing what it should, right? We would expect that to be lower in somebody who's being medicated for blood pressure. So they might need a higher dose, or they might need a different blood pressure medication, but not particularly most concerning, right? So thinking probably not. So that was a common side effect. So in their last option is feeling lightheaded when standing quickly. What might that be from? Well, they're on a blood pressure medication, right? And we said that orthostatic hypotension is common with blood pressure medications. So that's kind of, I guess, expected, right? We need to educate them that they need to be standing up slowly so that they don't fall over, but not really, it's not more concerning than a potential airway issue, right, of that possible angioedema. So it sounds like everybody is in agreement here that we are liking number 1 for the answer option. So let's check our answer. And yes, you are correct. Great job. All right, should we keep moving? What do we have for number 3? Therapeutic communication, everybody's favorite, right? All right, so the nurse is talking with a client who recently experienced a significant loss. The client states, "I'm doing fine, everything is okay." However, the nurse notices the client is frowning while speaking. And then we're being asked which of the following would be an appropriate response for the nurse to make. So we're looking for which one is the correct response. So to figure out what we're looking for, we need to read this header and stem really closely and see what it's actually asking us. So the client's saying everything is okay, but they're frowning when they're saying it. So we have incongruent communication between those verbal and nonverbal cues. So as a nurse, we want to get to the bottom of this, right? We want to figure out what's going on because they're saying everything's okay, but they don't look okay. So we need to figure out what's happening. And of course, we always want to use therapeutic communication when we're making these statements and when we're making inquiries into what's happening. So before we read our answer options, let's take a look at our therapeutic communication table to remind ourselves what we already know about therapeutic communication. And so we can basically break therapeutic communication techniques down into 3 categories. So we want to be active listeners. And so this usually comes in the form of restating or reflecting what the client has said in a very neutral way. You seem upset, or you didn't sleep well last night if they're telling you that they've been up all night. And then we want to ask open-ended questions. So therapeutic communication tends to follow a really specific pattern on the NCLEX. We're going to make a neutral statement, like a neutral statement that says we're listening, so some kind of neutral reflection. And then we're going to follow that up with an open-ended question. So you seem upset. Tell me more about that, right? And then, of course, we want to be really non-judgmental because nobody likes to feel judged, right? And so if we start saying things that convey that we're judging their decisions, they're probably not going to want to talk to us. They're going to clam up and probably not want to offer us a lot of information. Okay, so knowing that, let's go back and look at our options and see if we can figure out which one of these is correct. So our first one is, I can see that you're feeling upset. Tell me more about what's bothering you. What do you guys think about this one? It's not the worst statement I've ever heard, but it's not the best either. So I like this end one, the end statement where the nurse is saying, "Tell me more about what's bothering you." That's a nice open-ended statement, but what do we see? What's wrong with this? I can see that you're feeling upset. It's kind of judgmental, right? Like we're kind of assuming how they're feeling. We're saying, "I see that you're upset," and they might not be. We don't know. We don't want to put that on them. We want to make more neutral observations than that, right? So I think we could probably find something that's a little bit more therapeutic. So let's see what else we have. Our second option is, okay, I understand. If you want to talk more about how you're feeling, I'm here for you. What do we think? I mean, it's nice that the nurse is offering support, right? The nurse is saying, I'm here for you. But does this address the incongruent communication? We're not asking any question at all here. We're just saying, okay, well, let me know if there's anything you want to talk about. That doesn't give us any information because we're not asking any type of question, right? So that's not going to help us figure out what's going on. Now let's move down to number 3. I'm glad to hear everything is okay. Is there anything specific you'd like to discuss? What do you think? I see a closed-ended question right here. And we're not even acknowledging the fact that they're frowning. We're just like, okay, you said everything's okay. That's great. Let me know if there's something you want to talk about. And so if we phrase it like this, they're probably going to say no. And we're not going to get any information that we need. So that leaves us with our 4th option. And I see a lot of you are commenting that you like this as your option. So good job, because that is the only one we have left. So hopefully it's better. It says, you mentioned everything is fine, but your facial expression seems to show otherwise. I'd like to hear more about that. All right. What are you guys liking about this one? I like the fact that this is very neutral. We're just saying what we're observing. We're not saying that they're upset. We're just saying you're saying things are fine, but your face seems to show otherwise. And we're not making any assumptions as to what that means in terms of their emotions, but it's very neutral. And then we're following that up with an open-ended question. I'd like to hear more about that. We're inviting them to tell us about what's going on. So this one is probably going to get us the most information, right? So it sounds like everybody is liking that as our correct answer option. So let's go ahead and check. And yes. All right. And yeah, you've got it, Victoria. Give the client opportunity to talk more. Absolutely. Those open-ended questions are really good for prompting discussion. All right. So let's move on. Okay. So we have a mental health question now. We're caring for a client who has schizophrenia. So the nurse is observing a staff member caring for a client who has schizophrenia and is experiencing auditory hallucinations. Which of the following statements by the staff member to the client would require the nurse to intervene? So that's kind of a mouthful. We need to read that carefully, right? Because this is asking us which of the following statements would cause the nurse to intervene, which means we're looking for a statement that is inappropriate, right? We always have to read these really carefully. So we're looking for an inappropriate statement. So 3 of these are going to be correct and 1 is going to be incorrect. So we have to figure out which one that is. So before we look at our answer options, let's look at our handy table for communicating with clients who are experiencing delusions or hallucinations. Because remember, clients who are experiencing psychosis are not interpreting reality correctly. And so there are a couple things we need to keep in mind that are going to be different from how we would regularly communicate with somebody who was interpreting reality correctly. So I think it's going to be easier to start off with the things we don't want to do. So the first thing we don't want to do is to refer to hallucinations as if they are real. So that means we don't want to be saying things like, what are the aliens saying? Where are the robots at? Why are the spies coming to get you? Because this can reinforce that psychotic content for the client. Because if we're saying like, where are the aliens at? They're going to think we also believe that there are aliens there, and it's going to seem even more scary to them. So we don't want to do that. The next thing we don't want to do is that we don't want to negate the client's experience. So it's a little bit of a balance because we don't want to refer to the hallucinations as if they are real, but we also don't want to directly contradict what they're experiencing. So we don't want to say things like, there's nothing there, that's not real, that's not what's happening. Because remember, these clients truly believe that what they're seeing or what they're hearing is real. So if we come in and say, that's not what's happening, it could cause them to distrust us. And remember, these clients are already likely feeling paranoid. So if we start saying things that go directly against what they're experiencing, they might become distrustful of us and not want to talk to us at all. So what do we do? How do we communicate with clients experiencing schizophrenia? Well, we respond with very neutral observations. So we can give our observation of reality. We can say things like, I don't hear any angry voices, or I see Dr. Amber at the nurse's station, but I don't see any evil robots, right? So we're just giving neutral observations. We're not saying that what they're experiencing is or isn't real, okay? The next thing we want to do is to acknowledge the client's experience. So if we think about this, if these clients are seeing angry aliens, evil robots, they think people are out to get them, that's going to be really, really scary. And so we want to acknowledge their experience by saying things like, that must be very frightening, that sounds really scary, you're in a safe space, okay? And then lastly, we want to engage the client in distraction. So we could do this by like playing a card game. If they're having auditory hallucinations, we could do competing auditory stimuli like listening to music. The reason we do this is because it's really hard to attend to internal stimuli and listen to external stimuli at the same time, so it can help quiet those auditory hallucinations. And if the client is showing some insight into what they're experiencing, maybe a delusion or hallucination, we can start to engage them in reality testing. So again, we do this in a very neutral way. So we might say something like, let's look around. Does everybody else seem to be as fearful as you are? Does everybody else, or does anybody else in the room seem to be seeing what you're seeing, right? So again, we're not saying that they're right or wrong. We're just asking them to observe reality. Another thing that we might do is to coach them to tell the voices to go away if they're hearing voices, because this can help them feel more in control of their symptoms. It can kind of help quiet those auditory hallucinations. So now that we know some special considerations for caring for clients with psychosis, let's go back to our question and see if we can figure out which one of these would be inappropriate and would cause the nurse to intervene. So our first option is, why don't we go listen to some music together? What do you guys think? I like that. I mean, that's competing auditory stimuli, right? So that would be a nice way to distract them from their auditory hallucinations. So will we need to intervene for that? No, I don't think so, because that seems like a really appropriate intervention. Our second one is, let's go play a card game with the rest of the group. What do you guys think? I think that sounds fantastic. That is a nice form of distraction. We want to engage that client in simple, concrete, reality-based tasks, right? We don't want to leave them alone with their hallucinations to get kind of wrapped up in them. We want to bring them into the group, play a nice reality-based activity like a card game. So I don't think I would need to intervene for that. Yep, good distraction. You got it. Number 3, I will help you, and together we can tell the voices to go away. What do you think? Yeah, I think that would be appropriate. And we're not told up here how much insight this client has. So if they have a little bit of insight, that would be fine, right? Because it's going to help them feel like they have more control over their symptoms. So that just leaves us with number 4. What you're hearing is not real. You are experiencing a hallucination. What do you guys think? Well, remember we said we don't want to discredit what the client is saying. We don't want to tell them that what they're experiencing isn't real, because they're probably not going to believe us, right? And it could cause them to distrust us. So even if we weren't sure about any of these, we definitely know that we need to intervene for this one and give that staff member a bit more education about how to interact with clients experiencing schizophrenia. So it sounds like everybody is pretty much on the same page, right? All right, so let's check. And yes, we are correct. You guys are doing very well. All right, so we have one more question to go through, and this is a delegation question. Does anybody just love delegation questions? I always find them to be a little bit challenging, but that's why we have Dr. Amber as our expert in this area. All right, so let's see what we have. We have a charge nurse who is supervising a registered nurse in the care of a client on a mechanical ventilator. The charge nurse should intervene if the RN asks the unlicensed assistive personnel to do which of the following tasks. So again, if we're reading closely, we're looking for which would cause the charge nurse to intervene, which means we are looking for a task that would be inappropriate to delegate. Okay, so before we take a look at our answer options, we have a handy table for this as well. So let's just take a brief review of what we know about proper delegation. So first, we know it has to be the right person. So what this means, so in this case, we're dealing with a UAP or an unlicensed assistive personnel. So we need to ask ourselves, is that UAP competent, and do they have the skills and the knowledge to complete this task that we're asking of them? And then we need to be sure it's the right task. So is it within the UAP's scope of practice? Is it a routine task with an expected outcome? And then we need to have the right circumstance. So an example of this would be if we had a client who had a total knee replacement. So UAPs help with client transfers all the time, right? And that's within their scope of practice. They have the skill and the knowledge for that. They have the skill and the knowledge to be able to do that. But if it's the client's first transfer, would that be appropriate? Probably not, right? Because we need the nurse to assess that first transfer to determine if that client is stable, okay? We need to have the right direction and communication. So does that UAP verbalize understanding? Do they have any questions of what's being asked of them? And then lastly, the right supervision and evaluation. And basically what that comes down to is the nurse able to evaluate the task that they're delegating? Are they able to observe the outcomes? Because ultimately the nurse is responsible for those client outcomes, even if they're delegating that task. So let's go back and take a look and see if we can figure out which one of these would be inappropriate to delegate. Okay, so we have our first option, which is to turn the client from left to right every 2 hours. What do we think? Is that within a UAP's scope of practice? And do they have the skill and knowledge to be able to do that? I'm going to say yes, right? And the nurse can evaluate that outcome, because why do we turn clients? Probably to maintain skin integrity, right? And so the nurse can come and evaluate that. Yep, skin integrity looks good. This is within the UAP's scope of practice. They have the skill and knowledge to do it, right? So if we delegate that, I wouldn't feel like I'd need to intervene on that. That seems appropriate, right? Looks like you all agree. All right. Number 2, notify the RN when the client requires inline suctioning. What do you think about that? So I think what we need to ask ourselves is, how would the UAP know when the client needs inline suctioning? They would have to assess them, right? They probably have to assess lung sounds, O2 saturations, to know when that client needed inline suctioning. So is this within the UAP scope of practice? I'm going to say no, right? Because UAPs are not allowed to assess. And even if they had the skill and knowledge to do this, which they probably don't, it's not within the scope of their practice to assess. So I feel like I probably want to intervene for this, right? Looks like you guys all agree. Yep, that's for the nurse to do. You got it. So let's make sure, let's go and read all of our other options just to make sure we haven't missed anything. So we have our third option, which is to perform passive range of motion on the extremities. Is that within a UAP's knowledge and skill set? And is it within their scope of practice? I would say yes, right? It's a routine task with an expected outcome. The nurse can evaluate that after, because if we're performing passive range of motion, the goal is to maintain range of motion, right? So I don't feel like I would need to intervene for that either. And let's take a look at our last option, which is to measure the client's respiratory rate and pulse oximetry reading. So is it within the UAP's scope of practice to take vital signs and collect data? I would say yes, right? Because we're not asking them to interpret this data, right? Because in number 2, we're asking them to interpret data to figure out when the client needs suctioning. But in number 4, we're just asking them to collect these numbers and report them back to the nurse, right? So that is definitely within their scope of practice. They should have the skill and knowledge to be able to do that, yeah? Yeah, so it looks like you all agree we are worried about number 2, so we probably cannot delegate that task, right? We would need to intervene. Should we check our answer? We are 5 for 5. Good job. All right. So that brings us to the end of our study session. You guys have done very, very well. I am going to leave you with some links as to where you can find us. We're on Instagram, we're on TikTok, we're on YouTube, Facebook. You're in our study group right here. Of course, if you have any friends who are also studying for NCLEX, make sure that you hit that invite button on our Facebook page so that they can join in too, because we want everybody to feel ready and excited to tackle the NCLEX and pass. I'm going to hang out for a little bit. So make sure that you put your questions in the comments if you have any. I hope you guys have found this helpful. Or make sure you pop in there and say hi to Amber. We love to hear from students too. So if you're taking your NCLEX and you want to send us a note when you've taken it and let us know how it went and let us know if you found bootcamp helpful, if you have any suggestions for what you liked or what could be better, make sure you let us know. We'd love to hear from you. Oh, someone wants to see the delegation chart again. Yeah, we can pull that up. And this is on our website as well. It's linked in a lot of our delegation questions, so you'll be able to find it there if you're going through any of our delegation practice questions. Oh, Verona, thank you for inviting your friend. That's fantastic. All right. And Amber's leaving some links and helpful information there in the chat, so make sure you check that out as well. All right. Fantastic. Well, thank you so much for joining us. It's always fun to see everybody and hear all your comments. This will be archived on our Facebook page, so if you know anybody who wanted to make it but couldn't, it will be there so you can watch it later. All right, well, if anybody is taking their NCLEX soon, I wish you all the best of luck. I know you're going to do fantastic. And if anybody is graduating soon, happy graduation. I know you worked really hard to get here, so you all get cheers from us here at Boot Camp for making it this far. All right, well, take care, everybody, and we'll see you next time, okay?
So a little bit about me, while everybody's kind of telling me where you're from. I've been a nurse for about 14 years, and a majority of that nursing experience was emergency department. And then I went into nurse education about 7 years ago. I've taught at the university level, and my favorite job thus far is bootcamp.com, where I can help everybody prepare for NCLEX. So is anybody scheduled to take NCLEX soon? I know some people are already gearing up for NCLEX, already have test dates set. Other people are students that are just, in your curriculum studying. Either way, this should be a wonderful resource for you. Okay. So I want to go ahead and introduce Miriam. Miriam is another nurse educator for bootcamp.com, and she's going to be joining us in the chat today. She's going to be answering any questions you have and also sharing some information throughout the presentation. And so if you have any questions, just drop them in the chat. I do want to give you a little heads up. It takes just a couple minutes sometimes for us to see them. So if there's any delay, we're certainly not ignoring you. It might just take a couple extra seconds to answer your questions. But please, if you have any questions, drop them in the chat. Okay, so we'll go ahead and get started. So once again, I am Dr. Amber Adams. I'm one of the nurse educators here at bootcamp.com, and I'm so excited to be talking to you today about prioritization questions because once again, as an experienced nurse educator, it is very, very common for nursing students to say to me, I'm not quite sure which patient to see first. I'm not sure which task to see or do first. And so that's what prioritization really is all about. So today we're going to talk about what prioritization actually is. We're going to talk about how you should approach prioritization and then just discuss the general principles of prioritization. But before I do, I want to go ahead and remind everybody that if you have any friends or any other students in your cohort or anybody studying for NCLEX that you think will benefit from these resources and webinars, please head on over to our Facebook page. You can see right here, there's that invite and share button. Please let your friends know that we're here. We would love to help everybody pass NCLEX. Okay, so the reason we want to make sure we are very familiar with prioritization is because I can guarantee you that you will see a prioritization question on NCLEX. So whenever we are looking at the client need area or the test plan for NCLEX, we can see that management of care accounts for about 18%, 18 to 21%. And management of care topics are delegation, assignment making, but a lot of those items are prioritization. So you want to feel really comfortable navigating this type of question before you sit down for NCLEX. And one of the reasons prioritization questions are so commonly used is because they are one of the best ways to assess critical thinking, clinical judgment, and clinical reasoning. So Once again, NCLEX is a safety exam, and their main goal is to make sure that you have good critical thinking skills and good clinical judgment, and that's what prioritization questions do. So as we're approaching these questions today, we're always going to start by just looking at the overall client picture. And that's important both when you're taking an exam and when you're in practice at the bedside and you're trying to decide how to prioritize. You really need to look at the overall client picture and figure out that client's progression based on their disease process. And so that's what we're going to be doing today, is approaching these questions very strategically. Now, one thing to note before we get started on the practice questions is you may see prioritization questions worded many different ways. They're formatted a lot of different ways as well. You may be asked to choose among 4 clients or choose among 4 tasks. You might see words such as most important or priority finding or priority client, but all of these are ultimately just prioritization style items. So before we jump in the first practice question, I want to share this wonderful resource with you. So here at bootcamp.com, we are all registered nurses working on this study material and developing all this for you. And everybody has a great deal of experience in many different practice areas: OB, psych, ICU, ER, PD. And we all have many years of experience, and we know how difficult it is to navigate prioritization questions. So we came up with a wonderful resource to help you strategically approach priority questions. So we're going to use this prioritization pyramid throughout the webinar to kind of just help guide us as we're answering these questions. So I'm just going to very briefly kind of explain how it works. We're going to start with step 1. And that's where when we are trying to figure out which client is most sick or who needs to be seen first, we want to start by eliminating any stable and chronic clients. So let's give an example of these. A stable client might be a client that has maybe a minor wrist fracture, and they have some localized swelling and pain at that site. If we don't have any other information except a fracture with a little bit of pain and swelling, that is a very expected normal finding. That is a stable client. I'm not going to be too worried about them typically. So typically when I'm trying to figure out who's the most sick, a client like that, a stable one, I'm going to eliminate right away. And then we also have chronic issues. And an example of that might be a client with maybe advanced COPD, and they have a decreased pulse oximetry reading of 92%. Would we expect a client with advanced COPD to have a decreased pulse oximetry reading? Would that be an expected finding for a client with advanced COPD? Let's see what y'all have to say. I'm waking y'all up this afternoon. Yes, very good. So now if I gave you the same example where a client with a fracture had a decreased pulse oximetry reading, then maybe I should be a little more concerned because that's not an expected finding for that client. But for a client with advanced COPD, I expect decreased pulse ox. So that would be a chronic issue. And once again, I can eliminate it because I expect that for a client with advanced COPD. And then I'm going to move on to my prioritization pyramid. When I am looking at the rest of the clients that are not stable and don't have chronic issues, and I'm trying to figure out which one do I see first, I'm just going to work my way up this pyramid. So the bottom red, that airway and safety, is always going to be our number one concern. Any issues, acute issues with airway and safety, they can hurt our client really quickly. It's an immediate threat to them. They should be seen first, followed by breathing, circulation, and disability. And when I say disability, I'm just referring to neurological issues. So we can just go A, B, C, and D in safety. Those are going to be our big priority issues whenever we are navigating patient care and navigating these NCLEX questions. And then our lowest priority is going to be up here in green. And that's going to be any routine tasks, expected findings, and any psychosocial needs. And when I mean psychosocial, I mean the client is anxious or angry. Of course, we want to use therapeutic communication and address that client's concern. But typically, being angry is not going to kill our client. And that really, guys, is the foundation of priority questions, is what is going to kill our client fastest. So that's what we're looking for when we're navigating these. Okay, so let's get to our first question, because I know that's what you all came for, and we'll apply that prioritization pyramid that we just discussed. So the first question, the nurse should first assess the client who, okay? So we always want to just start by asking ourselves, what is that stem or header telling us? So in this case, we are being asked to select the client that is highest acuity or the most ill, so that we can see them first and make sure that their needs are met. So let's look at our options. Option 1, the client is obtunded, on hospice care and becoming restless. Option 2, had a cholecystectomy 2 hours ago and is reporting nausea. Option 3, a client with a peptic ulcer with a rigid abdomen reporting sharp abdominal pain. And then our last option, a client who had abdominal surgery 2 days ago and is reporting left lower extremity pain and swelling. Okay, so I see some people already putting in some answers. Okay, well, let's see if you're right. We're going to go through with the fine-tooth comb, a little more detailed with each option, and see which one we come to the conclusion of being correct. So our first one, our client is obtunded, which means, they are having altered mental status. They are on hospice care and they are now becoming restless. So I'm going to take this second to give you a really good test-taking tip. It is very important when you're navigating any NCLEX question, but especially prioritization questions, that you don't latch on to one keyword. So if we saw the word obtunded or restless, we would be typically worried about that client. We know that a change in mental status can be concerning, but we really need to pay attention to what this option is saying. It's saying on hospice care. So we know when we have a client on hospice, they have a terminal illness, and the progression of their disease or their condition is that they typically are, actively maybe dying. So whenever a client is actively dying, do we expect them to experience a change in mental status and maybe be restless? For a client with a terminal illness on hospice care, is this expected? Give y'all a couple minutes to let me know what you think. Yes, I 100% agree. So if we look over here at our little pyramid, that is an expected finding. So I'm going to put it way up top in the green, option 1. And then option 2, we have a client that had a cholecystectomy or a gallbladder removal 2 hours ago, and they're reporting nausea. So with a client that had a surgery 2 hours ago, especially an abdominal surgery, is nausea an expected finding? What do we think? Yes, I agree. And that's because, think about it, there's a couple different factors there. We have a client that just had anesthesia, and we know anesthesia alone can make us a little bit nauseated, have some upset stomach. Then we have a client with an abdominal surgery, so that's going to also create some gastrointestinal distress potentially. And then gallbladder problems alone can create nausea. So it is not unexpected, or it is expected, so I don't confuse anyone, that this client does have some nausea. So once again, I'm going to put this up here in option 2, and I'm also going to give you another really good test-taking tip. Don't add information to options. I was a nursing student, and I used to love to do that myself, but it's very easy to add stuff to that option, and you might start adding what ifs, like, oh, this client had a gallbladder surgery 2 hours ago. If they have nausea and then they vomit, we could have a problem with our sutures. No, it doesn't say that. It just says nausea. So let's trust what's there and not add anything, okay? Because that's a good way to get yourself in trouble on NCLEX and any other type of nursing school exam. So option 3, we have a client with a peptic ulcer with a rigid abdomen reporting sharp abdominal pain. So for a client with peptic ulcer, do we expect them to have some abdominal pain? Typically. But do we expect them to have abdominal rigidity or abdominal firmness? What do y'all think? Peptic ulcer, should we have a rigid abdomen or abdominal firmness? No. So I want to go ahead and tell y'all, anytime you see abdominal rigidity, that's a really concerning high priority finding. Because what can that mean? This is a bonus to wake everyone up. What does abdominal rigidity typically indicate? What condition are we concerned about? Peritonitis and a rupture. Yeah, very good. So remember, peritonitis, we have inflammation of that peritoneal wall, and it can be life-threatening, okay? It can certainly lead to sepsis, and it can be very life-threatening. So I would say for sure option 3, I would say probably a circulation issue, because if the client does have peritonitis and I don't address it, I'm going to have a circulatory issue real soon when they develop sepsis and they go in septic shock. So I'm going to put option 3 right here in circulation, and then let's look at our last option. We have a client with abdominal surgery 2 days prior reporting left lower extremity pain and swelling. So right away, if we have a client that had surgery a couple days ago and they have unilateral extremity pain and swelling, what am I going to be concerned about? I know y'all got this. DVT. Very, very good. So anytime we have unilateral extremity pain and swelling after that patient's been sitting in bed, chances are they've developed a blood clot or deep vein thrombosis. So with this client, that's also a circulation issue. So we have 2 that have circulatory issues, and that's where it can kind of get a little confusing. And we say, okay, well, we have 2 with circulation issues. Which one is the highest priority? Well, with our client with unilateral extremity pain and swelling, it's still very localized. There's no indications that there's any systemic issue going on, whereas peritonitis is very rapidly progress to sepsis, which is systemic. So option 3, even though they're both circulation, option 3 is really our highest priority. Now, let me talk to you about when option 4 could be potentially the highest priority. Is if this option instead said who had abdominal surgery 2 days prior with left lower extremity pain and swelling, and now has tachycardia, anxiety, difficulty breathing. What clinical condition am I going to be concerned about now? If I have unilateral extremity pain and swelling and suddenly I'm saying I'm short of breath, I'm anxious, I have tachycardia. Regina, you're rocking it. Yes, PE. Very good. So in that case, if we had indications of a PE, then that can become a breathing issue, and that is then going to be a higher priority. But once again, we're going to do a great job when we sit down and take the exam, and we're not going to add any information to the options. So let's see. And we got it correct. Y'all are rocking it. So I want to take this moment to say this type of prioritization question of identifying like the most ill client or the client that's the highest acuity is one of the most common ways you're going to see prioritization questions asked. But I want y'all to have a really well-rounded experience today and get some experience with different types of prioritization questions. So we're going to try a little bit different style now. But certainly this is the most common way you will typically see prioritization questions asked. Okay, so our next one. The nurse has been made aware of the following client situations. Which of the following client needs should receive the highest priority? So instead of client, it's client needs or task. Okay, so now we are being asked to figure out which task to do first. And that's, once again, why prioritization is so important, because that's what nursing is every day, right? 20 tasks to do, and we're like, which one do we do first? So let's look at our options. Option 1, administer an antibiotic to a client with cellulitis, and the antibiotic was due 1 hour ago, okay? Option 2, assess the client who's reporting redness and pain at their appendectomy incision site. Option 3, assign assistive personnel to stay with a client who is reporting suicidal ideations with a plan. And then our last option, provide discharge education to a frustrated client who has been requesting discharge paperwork for 2 hours. So I see a lot of people are choosing an answer that they like. So let's talk, though, a little bit about why that might be correct. So our first one, administering an antibiotic to a client with cellulitis. If we are to delay antibiotic administration briefly, is that going to typically create any type of life-threatening risk to a client to delay an antibiotic dose? Not typically. So certainly, medication administration is very important and we want to administer it in a timely manner, but typically delaying one dose is not going to create a life-threatening issue. And that's what we just have to ask ourselves as we do each option is, if I delay whatever is here, am I going to create any type of life-threatening or immediate risk to my client? And that's what you want to always ask yourself when you're doing these prioritization questions. So the next one, Our client has redness and pain at the appendectomy incision site. So what does that probably indicate? You have a client that has a surgical incision and they're having redness and pain. What do we most likely have going on? I know y'all know this. Infection, very good. So once again, it's very important that we assess that site and that we notify that provider, because we might need to intervene if that client's developing an infection. But delaying the assessment for a minute is typically not going to create any type of life-threatening issue. And then the option you guys all are loving is option 3. Okay, so let's talk about why that might be a really high priority option. We have a client that is not only reporting suicidal ideations, but suicidal ideations with a plan. So we all know suicidal ideations already are concerning, but anytime a client has a plan, they're typically pretty serious about that. They're typically going to attempt suicide because they've had time to think about it, develop a plan on what to do. So that is a client that is a huge safety issue. So way down here on very highest priority on our pyramid, a safety issue. So I agree with y'all. And then let's look at option 4. Provide discharge education to a frustrated client who has been requesting discharge paperwork for 2 hours. So I would also be frustrated if I was waiting 2 hours for discharge paperwork. So I'm sympathetic. But once again, a client being frustrated or angry, it's typically not going to pose any type of life-threatening risk to that client. So certainly we'll use some therapeutic communication, get them discharged, but they are not our first priority. So I agree with you guys. Option 3 looks like a great option, and y'all are correct. So now I want to work completely backwards a little bit, and I'm going to do the last item 3, and we're going to talk about basically identifying the client that is least sick or the lowest priority. So we're once again kind of going to work backwards a little bit, but I wanted y'all to get a good idea of how you might see prioritization questions asked many different ways. So item 3, the nurse is caring for admitted clients involved in a mass casualty incident. So the nurse must discharge a client to make a bed available for more injured clients. It would be most appropriate for the nurse to recommend discharging the client with, and we have our 4 options here, a contusion to the chest wall with a heart rate of 110, soot around the nose and mouth and a respiratory rate of 30, headache and bruising behind the ear following a head injury, and then option 4, superficial non-bleeding abrasions to the face and upper extremities. Okay, so let's look a little closer. So with our client in option 1, if we have a contusion or a bruise to the chest wall and a heart rate of 110, what are we concerned about? Is there any clinical condition that you guys are concerned about right away? I've clearly had some blunt force trauma or some sort of trauma to that chest to create that bruising. And I'm a little bit tachycardic. We know 110 is a little bit fast. So what do y'all think might be going on with this client? I see a lot of people wanting to select 4. Well, don't you worry. We'll get there. We're going to see if we can tease out a little bit more knowledge out of the rest of these options while we're at it. So what do y'all think? Bruising to the chest and tachycardic. Is there anything that y'all are worried about? Internal bleeding, maybe, but there's something you're not wrong. You could have internal bleeding, but there's something I'm worried about. You want me to help you out? So anytime we have trauma to that chest and we have a heart rate of 110, you guys aren't wrong. Pneumothorax it could be. But I'm really going to be worried as well about cardiac tamponade. So do y'all remember what cardiac tamponade is? That's when we have fluid surrounding that within that pericardial sac, surrounding that heart. And so that heart can't pump effectively. So we're going to have decreased cardiac output. And then we start seeing a lot of signs of inadequate perfusion, such as tachycardia. But good call. Pneumothorax also can cause tachycardia. Y'all are doing a phenomenal job. So either way, that is for sure either going to be a circulation issue if it's cardiac tamponade or a breathing issue if it's a pneumo on our little pyramid over here. So we know right away option 1 is pretty high priority. So option 2, soot around the nose and mouth. Anytime that we could stop right there. Anytime we see soot or ash around the nose and the mouth, is there any condition y'all are concerned about? me working ER, there's something that I'm real nervous about the second I see that. While y'all are typing, I'll go ahead and mention too, that respiratory rate of 30 we know is a little fast, so our client's a little tachypnic. So yes, they are tachypnic, so we are having a little bit of respiratory distress. But what should we worry about when we see ash or soot around that nose and mouth? Carbon monoxide is a possibility. Inhalation burns. Leandry, is that how I say it? I hope I said it right. Great job. We're worried about an inhalation injury. So anytime we see that client has soot or ash, we know that they've inhaled smoke. And with that, we can either have an inhalation injury that's going to cause that airway to narrow and a lot of times require intubation, or best case scenario, it's just going to maybe cause some respiratory distress a little bit lower than that airway. And either way, it's an airway or a breathing issue. So once again, high priority. Option 3, a headache and bruising behind the ear. So once again, if I see bruising behind the ear after a head injury, that's kind of a cardinal symptom. Something comes to mind. Anybody know what causes bruising behind the ear? Let's see. So you can have intracranial bleeding, Kat. Yeah, so we can have some bruising in this, like at the skull. If you have intracranial bleeding, that's a concern, but also basilar skull fractures. So anytime we see a bruise behind the ear when our client has had a head injury, I'm right away going to be concerned about a skull fracture. So, either way, intracranial bleeding or whether it's, skull fracture, circulation or disability, still very high. So I'm sorry guys, I keep trying to erase my options. Okay, there we go. So we can see the first 3 options are really high priority issues. And then we see our last option are superficial non-bleeding abrasions to the face and upper extremity. That's typically not going to create any type of life-threatening issues for our client. That's more of an expected finding. So it's definitely lowest priority. However, if it said that client was experiencing profuse bleeding or they were actively bleeding, then that becomes more of a circulation issue and higher priority. But in this case, once again, we're not going to overthink it. We're not going to add information. We're just going to trust what it says. April, you said battle sign. Kudos to you. If I had a prize, I'd give it to you right now. Very good job. That's that bruising behind the ear. Very good. So option 4, I agree with all of y'all, is most likely our correct answer. And it is. Y'all are rock stars. Y'all are doing a great job today for Nurses Week, huh? Showing off. So once again, I want you, when you're sitting down doing prioritization questions, or more importantly, when you were at the bedside and you were trying to figure out what task to do first or which client to see first, remember, approach it from a very strategic standpoint, okay? When you're looking at items on an exam, don't try to tease out keywords or anything like that. Think about the client and the overall picture and what's going to happen if we do intervene or if we delay. And that's really going to help us be able to determine, what's the true priority. So I hope this webinar today helped y'all doing some of these practice questions. But I want to remind you guys, on bootcamp.com, we have a ton of prioritization questions for practice. And I want to give everybody an opportunity to ask any questions. So while y'all are asking questions, I want to briefly show y'all something. If you give me 1 more minute of your time, I know y'all are busy. If you go to bootcamp.com/NCLEX, you will see our website. You don't have to even create an account or give us any type of pricing information, nothing like that. You can just literally hit start studying for free, and you automatically have access to some free resources to go ahead and get you started. And I will tell you, we have had so many students come back recently and say that our product seems to look closest to NCLEX. So we have some really well-developed case studies. I'll show you real quickly. If you click on it, you can see these are, once again, we're all registered nurses, very well-developed case studies we've created that will certainly resemble NCLEX and get you prepared so that when you sit down to take NCLEX, it feels very comfortable and familiar. So please check us out at bootcamp.com and certainly follow us on all of our socials right there. And I know Miss Miriam also probably put it in the chat. So any questions at all? Of course. course. I see a lot of thank yous. Of course, I once again, I love doing this topic because I know it's challenging for students. So I'll wait a couple more seconds, see if anybody has any questions for us. Happy Nurses Week to you. Okay. So like I said, I'll hang out for just a couple more seconds, see if anybody has any questions. I hope this helped y'all, and I hope y'all have a wonderful week. Is there a SATA session soon? Select all that apply. So, you know what, Shan? I'm not going to lie to you. I do not have the schedule memorized, but I know that I believe next week we're going to go through quite a few different kinds of item styles. These are recorded, yes. Don't you worry if you go to our Facebook page, it's recorded there. You can watch it over and over, share it with your friends, please, so everybody can feel really comfortable with prioritization questions. You said our fall's highest priority. So that's going to be a safety issue, okay? So anytime you see where they're describing a client that is at risk, high risk for falls, certainly that's going to be safety. That's going to be very, very high on our list of priorities. Very good question. What is disability? So disability, Corbin, is going to be neurological. And so that's going to be, signs of stroke. Like maybe the client is developing numbness, paresthesia, difficulty speaking, difficulty swallowing. And you see that term like interchanged a lot, disability and neuro, especially whenever you start learning more about trauma and that kind of thing. So, but yeah, that's what it is. It's just neuro findings, changes in mental status. Hopefully that helps. How many months do you recommend to prepare? Well, that's going to depend on just when you have your tests scheduled. One thing that I know Miriam has probably put in the chat, but that we can make sure we have in here, is that we do have some study schedules created depending on how long you have before your scheduled exam, and it helps guide you. So it takes the guesswork out for you so you can know how long you need to study, and it also tells, there we go, Miss Miriam put it right there, the 12-week study calendar. And I know some students are going to have more time than 12 weeks and less than 12 weeks, but certainly that will help get you started. Okay. So, 5 subjects fell. Okay, so you've had some issues with nursing school. Okay, so one of the best things I recommend is in your downtime before I know a lot of times nursing schools require you to take time off before you get into the next course. One of the best things you can do is certainly use study resources like NCLEX.com in the meantime, so you can brush up and really strengthen the areas you're weak in, so that when you get back in that course, hopefully you feel a little bit stronger and a little bit more well prepared, and you have kind of more of a foundation. Ingrid. So Ingrid, the same thing. I would certainly start by just doing a predictor exam, figuring out where your weak points are, and really brushing up on those and strengthening those. Can I go back to the priority slide? There y'all go. And so once again, this is recorded, so you will be able to watch this as many times as you want on our Facebook page and share it with your peers. Okay. Well, guys, I'm about to let you all go because I know I've kind of held y'all over a couple extra minutes. Testing in a few days. Good luck. Good luck. You got this. Okay, guys. Well, I hope y'all have a wonderful rest of your Nurses Week. And I hope this webinar helped you all and you feel a little more comfortable with prioritization, and we'll see you next week. Okay, well, we'll give everybody another minute or so to go ahead and get logged in. Once again, I'm going to introduce myself. My name is Dr. Amber Adams. I'm one of the nurse educators here at bootcamp.com. And I have Krista joining me in the chat. She is another nurse educator that is going to be answering any questions y'all have and sharing some helpful information throughout the webinar. You said it is 10 p.m. there. Wow. Well, thank you for joining us so late. Hopefully you really enjoy it and learn a lot. Okay, so once again, this webinar today is on delegation and assignment making because we thought it was so important to really discuss management of care topics. So whenever we are looking at NCLEX, management of care topics account for almost 20% of the exam, and delegation and assignment making can be a very intimidating topic. It just doesn't always come as intuitively as discussing disease processes and pathophysiology. So today we're going to talk about some helpful tips and tricks to get through these types of questions. Okay, so going ahead and before I get started, I want to remind everybody to please invite your friends. On my screen, you should see in this little red box that invite button on our Facebook page. Please share our Facebook page and invite your friends that are studying for NCLEX or are in nursing school and you think would just benefit from some really good study resources. Okay, so today, once again, we are going to talk about appropriate delegation and assignment making. We're going to talk about the nurse's role in delegation, and we're also going to discuss the 5 rights of delegation because those are very important. Even on the NCLEX test plan, they talk about how important it is to really be familiar with those 5 rights of delegation. And then we're going to do a couple of practice questions, of course, because I know that's what you all came for today. So once again, management of care includes prioritization, delegation, assignment making, and they do account for almost 20% of that NCLEX exam. So that means I can guarantee you that when you sit down to take NCLEX, you're going to have some delegation items. So that's why you really want to feel comfortable with this skill. So once again, guaranteed to see delegation and assignment making on NCLEX, but I want to remind everybody that delegation is not as simple as just asking somebody to perform a task. Delegation is a very complex nursing skill, and it really can get us in a lot of trouble if we don't delegate properly. It can create a lot of risks for our patients and a lot of legal liability for us where we can lose our license and practice if we don't delegate successfully. So, it is very frequently used, especially, nurses' workload is busier than ever, so it's more and more important that we feel comfortable with delegation. So a couple helpful tips I want to start off with right away that will help you navigate these items is 1, we don't typically delegate the nursing process or any task that requires nursing judgment. And we're going to talk a lot more about that throughout this webinar, but it is very important that we are not, once again, delegating those steps of the nursing process. The assessment, the evaluation, the diagnosis, all those things. That is the nurse's role. And we also only ever want to delegate tasks on clients that are stable. Any unstable client, that registered nurse should be at the bedside caring for. We shouldn't be delegating tasks for unstable clients. And then we're also going to talk a little bit in this webinar today about assignment making principles, which isn't as commonly discussed as delegation, but there's a good chance you'll still see it on NCLEX. So whenever we are looking at delegation items, it is very important that we familiarize ourselves with and are comfortable with the nursing scope of practice. And basically that's just what is everybody's role. All the people you're working with in the unit, providing care for patients with, what can each person do? We must be familiar with that in order to know if something is appropriate to delegate. And then also, once again, those 5 rights of delegation that we're going to discuss today. Now, I always want to remind everybody that anytime you're faced with, any type of management care topics, prioritization, delegation, ethical and legal, all those types of things, it's really important that we, use our resources. And once again, with delegation, scope of practice and 5 rights of delegation are very important to utilize when we're doing these questions. Okay, so we're going to really briefly talk about care provider scopes of practice. So we're going to start with the registered nurse. So the registered nurse obviously has the largest scope of practice in the clinical setting. We are responsible for all parts of that nursing process. We're responsible for caring for all clients, no matter how unstable they are. And so we ultimately are responsible for all the clients. And we, once again, have the largest scope of practice. And we can care for any patients, no matter how unstable they are. And then there is the licensed vocational nurse or licensed practical nurse. It's the same role, they just have different names depending on where you live geographically. And they also are absolutely nurses, but their scope of practice is a little bit more limited, although you don't always see that in real life. Me personally, I was an LVN before I was an RN, and it was not uncommon in the clinical setting that I would be asked to perform tasks that were really not within my scope of practice. So it's really important we familiarize ourselves with that. So although LVNs can perform some parts of the nursing process, that RN is responsible for all the initial steps of the nursing process. So as the registered nurse, we're responsible for that initial comprehensive assessment. We're responsible for that initial education, all those types of things. Whereas the LVN, they should really be doing mainly just focused or targeted assessments, and they are really only supposed to be providing care for stable clients. Okay, that registered nurse is providing care for unstable clients. That LPN or LVN, it's typically should only be assigned to stable clients. And although they can do education, they should only be reinforcing the client education that the registered nurse has already provided. So they just reinforce that client education. And then lastly, a lot of the delegation questions that you're going to see on an exam typically involve that RN delegating to a UAP, or an unlicensed assistive personnel. And they have the smallest scope of practice. Typically, they're just responsible for collecting data and really performing only routine tasks for very stable clients. And they do not ever provide client education. That's not at all within their scope of practice. Neither is the nursing process. They should never be doing any assessment, any evaluation, anything like that. And so now that we're familiar a little bit with the scope of practice, let's briefly talk about the 5 rights of delegation. So the 5 rights of delegation are just basically questions to ask ourselves to determine, are we performing delegation appropriately? So the first one is the right person. So as the registered nurse, anytime I'm delegating, I need to make sure, is the person I'm asking to perform a task competent? Do they have the knowledge and the skills needed to perform the task safely? And then I have to make sure, is it actually the right task? Is it a task that's within their scope of practice? For example, I would never ask, once again, a UAP to do client education. That is not an appropriate task within their scope of practice. We also have to ask ourselves, is that task routine with an expected outcome? Or is it, maybe an experimental procedure? Or is it something that we're not really quite sure how that client is going to tolerate? If so, we certainly don't want to delegate that. And then we have to look at the right circumstance. Is our client stable? And is there adequate supervision available? We all know, y'all have all been in the clinical settings, I'm sure, that delegation is most frequently used whenever we're very busy. But part of delegation is no matter how busy we are, we should never delegate a task if we as the registered nurse are not available to adequately supervise and be present to make sure that task goes okay. And we have to make sure all the necessary resources are available to perform that task. And then the last 2, right communication and evaluation. So with communication, we have to be very specific. We should, for example, instead of saying to a UAP, can you please tell me if that client's blood pressure is unstable? We need to say, can you please tell me if that client's systolic blood pressure is above 120? So it's about giving very detailed instructions, very detailed communication, and giving that person, that delegatee, that UAP, an opportunity to ask questions. And then the last one is right evaluation. We need to make sure that that delegatee or that person performing the task had, adequate supervision, adequate availability to talk to that RN, and we need to make sure, was the task performed correctly, and was there appropriate feedback provided? Because as the registered nurse, part of the role of delegation is going back and telling that person what went well or what could be even better next time. So I know that was a whole lot of information I just gave y'all, but now we're going to apply all that, and we're going to apply that to a couple of questions, and hopefully y'all are going to feel really confident about delegation items when we're done. So the first practice question, the registered nurse is supervising unlicensed assistive personnel, or UAP. So which task is most appropriate for the nurse to assign to a UAP? So let's look at each option in a whole lot of detail, okay? So I love participation. It makes it more fun for me, certainly, and for y'all. So please, as I'm asking questions, I'd love to see y'all's ideas and responses. So the first option, perform incontinence care for a newly admitted client who had a cervical spine injury. So what do you guys think? Do y'all think that we would want to delegate incontinence care for a newly admitted client with a cervical spine injury to a UAP? A couple people are saying 2. So we'll talk. Don't worry, we'll get to the right answer. But I think y'all are on the right track. So I see a lot of no's. So why? why would that not be an appropriate delegation assignment? Because that's where the learning is. That's what's important. That's what y'all came here for. So with incontinence care, what do we need to do? If we want to make sure our client is really clean and that we're doing a great job to prevent skin breakdown, what does that involve? I see a lot of people saying newly admitted. See cervical spine injury. Okay, so y'all are 100% on the right track. Shan, moving them. You are correct. So anytime we're performing incontinence care, if we want to do a good job and prevent skin breakdown, that involves a lot of client manipulation or client movement. So certainly we know anytime a client has a cervical spine injury, what kind of technique do we need to use to move them or roll them? Anybody tell me? Log roll technique. So remember, that's a specialized way to move them that usually involves multiple people to prevent any type of worsening of that spinal injury. So we certainly do not want to have a UAP go and be turning a patient with a cervical spine injury, because we can worsen that spinal injury. And if they don't already have neurological issues or paralysis, we can then cause it. But also, y'all are right on target. I see a lot of people typing newly admitted client. So this is a helpful tip for NCLEX. We talk a lot about stable clients, unstable clients. Anytime you see on an exam that a client is newly admitted or just arrived to the unit or anything like that, that is a client that should be a red flag for you. Just an indicator that that registered nurse needs to be the person at the bedside doing whatever it is, because we don't know if they're stable. We have not seen them. So I agree with y'all. We're not going to delegate that. So let's move on to 2. And I know y'all like 2, but let's talk about why. So we have a client with an above the knee amputation 2 days ago, and we want to put them in the prone position. So why do we put clients with above the knee amputation in a prone position postoperatively? Does anybody remember? And I want to go ahead and apologize. For some reason, whenever y'all comment, it's always delayed on my end. So prevent contractures. Very good job, Michelle. So yes, whenever a client has an above the knee amputation, we want to keep those hips flexed, because we can have contractures, and which can create a lot of problems down the road for those clients. So we want to put them in that prone position to keep the hips flexed, typically about 3 to 4 times a day. So this is just assisting a client in the prone position, is once again just repositioning. From the information we have, it was 2 days ago, so chances are they have been repositioned many times, and this is a pretty routine task, and there's nothing to indicate that this client is unstable. So I love that answer too, but let's talk about the other options. Option 3, reposition a client with increased intracranial pressure or increased ICP who has a decreased level of consciousness or altered mental status. So why do y'all not want to delegate that? What do you think? Unstable. Very good job, Tanya. Unstable. Remember, anytime a client has any issues with intracranial pressure, when we start seeing decreased level of consciousness or altered mental status, that is an indication that our client is unstable and they are getting worse. So once again, we don't want to ever delegate any task on an unstable client. And additionally, when a client has increased intracranial pressure, we have to be very, very careful with repositioning. As the nurse, what kind of position do we want to put this client in? Any client with increased intracranial pressure or a client at risk for increased intracranial pressure, how do we typically position them? Semi-fowlers, yeah. We want to keep that head of the bed elevated, and we also want to keep the neck in a neutral position. So if we have somebody reposition them and that neck is, flexed, or they're, laying back too flat, certainly we are just going to make that condition worse. And we can cause a lot of problems with, brain herniation or tissue ischemia to the brain. So very good job. I don't like delegating that. And then the last one. Demonstrate use of a continuous passive motion device, or CPM, for a client who underwent a knee replacement. So why would we not want to delegate that? That seems like a very routine task. And y'all recall what the CPM device is, post-knee replacement. It's that machine that makes that knee go into a stepping position to prevent scar tissue buildup. Okay, teaching. Very good job. Not in their scope of practice. So I want to remind everybody right now that you're not always going to see on NCLEX the word educate or teach or assess. They don't always make it that easy. So demonstrating use is just another way of saying education. So you just have to pay attention because you're not always going to see those keywords. But you're 100% right. Even though it's a pretty, seems like a routine task, demonstrating use is just another way to say educate, and that is not within the scope of practice. So once again, for option 1, they're unstable. Option 3, they're unstable. And option 4, it's outside their scope of practice. So I think we got it correct, and we did. So good job on the first item. I loved y'all's participation. Keep it up. Y'all are doing a great job. So then question 2. So I know that everybody loves SATAs, right? No. So I know it can be pretty intimidating whenever you sit down to take an exam, especially when you get to sit down and take NCLEX, and all of a sudden there is 7 answer options on that screen. It's like, oh my goodness, I'm feeling overwhelmed. But remember, with SATAs, we're just going to take them one option at a time, and we're going to treat them like true or false. So it says the nurse is caring for 5 clients on a telemetry unit. So we're having a busy day in nursing. So which of the following client needs can the nurse delegate to an unlicensed assistive personnel, or UAP? And a lot of times you'll see these delegation style items as SATAs. Sometimes it'll be on one client, sometimes it's on many different client needs. So you'll see these SATAs a lot. So let's look at our options. Option 1, determining the pain level for a client that just received IV morphine. What do we think? True or false? Yes or no? Do I want to delegate that to a UAP? No, a UAP cannot assess pain. So, this can be kind of a tricky area. Or false, Ireland. Yes, true or false. So whenever we ask a UAP to do vitals, typically, that's a routine task. And sometimes they can, collect a pain level as part of the vitals. However, we just received IV morphine. So determining a pain level, once again, determining is basically another word for assessing. So assessing the pain level for a client that just received IV morphine is basically not only assessing a client, but it's also evaluating the care plan. We are evaluating whether or not a medication worked, and that is part of the nursing process. So I don't like that option. So option 2, assessing a client's ability to swallow food prior to feeding them lunch. What do we think? Aspiration risk, Michelle. Okay, very good. And this item's kind of easy because it straight up says assessing, and we've already said that that's out of that UAP scope of practice. So assessing a client's ability to swallow food. They cannot assess, and also, as you said, it's a huge aspiration risk. So what would be more appropriate is that registered nurse would go assess the client's ability to swallow, and then if we determine that that's safe, then they could assist helping them feed. But we are not going to have them assess the ability to swallow food, way outside their scope of practice. Option 3, do we like that? Assisting a client admitted with pancreatitis to ambulate to the restroom. What do y'all think? Oh, Mary, you've given us the answers. Good job. Yes, y'all like that option. I like it too. So that is a very routine task. We're just ambulating a client to the restroom with pancreatitis. And remember, pancreatitis is just inflammation of that pancreas that usually is not going to have a lot of mobility issues. You just have some nausea, vomiting, pain, that kind of thing. So that should be a routine task. Option 4, assisting a client admitted with a myocardial infarction or an MI to perform oral hygiene. And this is where, while y'all are answering, I want to go ahead and just remind y'all, it is very easy, especially when you're nervous and taking an exam, to add information or overthink things. And myocardial infarction sounds like a pretty, serious diagnosis, a pretty intimidating diagnosis. But remember, we're just performing oral hygiene. Don't read into it. Don't think, oh, it's an MI, they must be really sick, that kind of thing. It's just oral hygiene. There's nothing that says they're unstable. So I like it too. Y'all are all saying yes, I agree. And then option 5, performing pericare on a client with an indwelling urinary catheter in place. Michelle, MI has nothing to do with brushing their urine. You're right. But sometimes it's easy, to go down that rabbit hole where you're like, oh, well, maybe with the myocardial infarction and keep going and get yourself in trouble. So y'all are all saying yes. I agree also. Performing pericare is a very basic task, and this client is an indwelling urinary catheter in place. But also, let me give you an example of when this would be maybe phrased as an unstable client that we shouldn't delegate. Maybe if it says performing pericare on a client with an indwelling urinary catheter with blood at the urinary meatus or with bladder distension or any of those types of things. That would be one of those situations where that client potentially is unstable and we would not want to delegate. So option 6, recording the intake and output of a client with a history of CHF. What do you guys think? Michelle, you said, or if that Foley catheter has no output. Very good point. I agree with you 100%. So I'm seeing a lot of yeses to option 6, recording the intake and output. I agree. So let me give you another example of how this might look if it was something we shouldn't delegate. Maybe it says recording the intake and output of a client with CHF with flash, or let's say with pink frothy sputum. What does pink frothy sputum, because that's a very high yield clinical finding that you may see on the exam. What does pink frothy sputum typically indicate in a client with CHF? This is a bonus question. But I will tell you, it's always a very high priority finding. Michelle, you said pulmonary edema. Very good. Flash pulmonary edema. Anytime, say you're doing a prioritization item or you're reading about a client that has flash pulmonary or pink frothy sputum, that's flash pulmonary edema, very, very high priority. So if it said something like that, certainly we're not delegating. So the last one, performing vital signs on a client that just returned from the cardiac catheterization unit, otherwise known as the cath lab. Performing vital signs, no. Okay, so somebody tell me why. Because once again, usually vital signs are a very routine task that UAP can perform for us. So why in this case do we not want? It's an initial assessment. RM should perform the initial vital signs. Very good, Lainey. So yes, that's another helpful tip for NCLEX. Anytime you have a client that once again just returned from a procedure, you want to consider them unstable, okay? So that is certainly not something we want to delegate. It's when a client is first coming back from a procedure, no matter how mild the procedure might be, that registered nurse needs to be the one that's assessing them and performing those initial vital signs. But especially, cath lab, think about it. We've manipulated that heart tissue to, check arterial blood flow or open up a blockage. So a lot can go wrong with bleeding, with arrhythmias. So certainly we do not want to delegate that. So y'all did a phenomenal job with these delegation questions. So let's move on and shift gears just slightly and talk about assignment making, because we talk a lot in general about delegation, and assignment making isn't as commonly discussed, but you still will very likely see assignment making items on NCLEX. So it says a charge nurse is making client assignments for a critical care step-down unit, or that's typically one step below ICU. Which client would be most appropriate to assign to a new graduate registered nurse? So before I jump in the options, I want to remind everybody that registered nurse technically can care for any client. We once again have that large scope of practice. We can care for all kinds of unstable clients. But remember, with NCLEX, we live in a perfect world. We have this NCLEX hospital where staffing is great, and it says most appropriate. So we want to find out which one would be safest for that nurse and that client. So option 1, a client admitted for diabetic ketoacidosis on insulin drip, DKA. I know, y'all are so smart. Y'all are all guessing the right answer, but let's talk about why. That's where the learning occurs, right? So a client with DKA on insulin drip. So why do we not want to assign that? So Michelle, you're rocking it today. Hypoglycemia risk. Very good, but also let's talk about with DKA and insulin. We typically have, when we're given IV insulin, there is constantly, electrolyte, like there's cellular shifts. So we are at risk for potassium imbalances, which can certainly create some cardiac issues. Also, insulin is one of the highest risk drugs you will ever give. If you accidentally hit bolus on an insulin, there's a good chance that patient's not going to make it. So it's a very high risk drug. You want a nurse with specialized knowledge of insulin drip protocols. Also with DKA, we are constantly monitoring that blood sugar. very, very frequently. So you want somebody that's very experienced and skilled that can handle this client, because there's a high risk for, complications, because it's a complex care plan. Ireland, good job. You said dual sign off too. Yeah. Anytime we're giving insulin, you do want 2 nurses to verify the doses. So very good. Y'all are doing great. I'm super impressed. So option 2, a client that is scheduled for discharge today that has a new colostomy. So that's a very stable client. They're going home today. So why don't we want to give that to the new grad nurse if we can help it? What do we think? Teaching, very good, very good. So teaching, we want a nurse that's probably has a lot of experience with colostomy care, with wound care, so that this client has a decreased risk of complications once they leave the hospital. Because that's going to be very complex discharge teaching to teach a client about a new colostomy. And there's also a lot of psychosocial considerations there too with adjusting to the new colostomy. So you really kind of want a nurse with specialized experience with that. Okay, option 3 that y'all love so much is a client admitted for a post-operative infection receiving IV antibiotics. So y'all love that one. So why do y'all love that one? I mean, I like it too. I think it's probably even the right answer. But what do y'all think? Why would we want to assign that client to a new graduate nurse? More stable, yeah. So this client is probably has the most simple care plan. They are typically going to need, vital sign monitoring, IV antibiotics. It should be something that new graduate nurse feels very comfortable managing. However, let me give you an example of when this same client wouldn't be maybe the most appropriate. If it said a client admitted for a post-operative infection that is experiencing hypotension with an elevated lactic acid level. Can anyone tell me what clinical condition that client would probably have if they have an infection and now they have hypotension and they have elevated lactic acid? This is just another bonus question. Sepsis. Good job, Sage. Yes. So anytime we have elevated lactic acid, we have hypotension, signs of decreased perfusion, that's an indication of sepsis. And that we would not want to assign to a new grad RN if we can help it, because it usually requires hemodynamic monitoring, administration of vasopressors, those types of things. And then a client scheduled for pacemaker insertion during the shift. And once again, why do we think that we don't want to give that to a new grad RN? Y'all are making this so easy. Y'all are rocking this. Okay, Geetha, you said unstable. So they do have a potential to be very unstable, because remember, when they're coming back following a pacemaker, there's a high risk for arrhythmias. So we want a nurse that's very experienced with rhythm interpretation, ECG rhythm interpretation, so they can see if that pacemaker is not picking up properly. There's a lot of risk for bleeding complications, and once again, that pacemaker doesn't always work properly sometimes. So we need somebody that's very, very familiar with monitoring that ECG rhythm. So y'all are doing phenomenal. Okay, so overall, I know that's just 3 brief questions. We have many, many more on our website. But remember, delegation, I guarantee you, you're going to see, can't even talk today, sorry. I guarantee you, you're going to see delegation on NCLEX. So you want to keep practicing these types of questions and familiarizing yourself with those 5 rights of delegation, and really paying close attention to the scopes of practice of everybody in that clinical environment. Remember, delegation is a huge safety issue for you and your license, but also for your client. Once again, we're always remember, we're not going to be delegating that nursing process or clinical judgment. And we're only delegating tasks for stable clients. So that's the big takeaways to remember when you're sitting there and you're trying to figure out between 2 answer choices. So I know I want to give everybody an opportunity to ask questions because we covered a lot today. But while y'all are putting in some questions in that chat, because like I said, there's a little bit of a delay, I want to briefly show y'all the bootcamp.com/NCLEX website so y'all can kind of see the different resources that are available. So when we click on that, we can see right away you can start studying for free without entering any information in. So certainly you just hit that Start Studying for Free button, and you will immediately have access to all kinds of resources. But one that students seem to love and that we hear a lot of positive feedback about is the case studies. So as we know, NCLEX has a lot of case studies, and they can be kind of intimidating. So let's take a quick look at how well developed these case studies are. They very, very closely mirror NCLEX. You can see the different patient tabs, the nurse's notes, H&P, vital signs, all these types of things. And they, once again, very closely mirror the NCLEX. So please check us out. Take a look at a couple of those case studies and invite your friends to come join us for these future webinars and to access this information. Also, follow us on all our socials because, I don't know what just happened there. Follow us on all our socials because, as y'all know, we typically have these webinars weekly, and they're in all different types of topics. If you want some more management of care topics, we did a prioritization webinar 2 weeks ago. Please check it out. They are saved on our Facebook page, but that way you can certainly join us for future webinars. So thank you. I see a lot of thank yous. You're so welcome. I love talking about this topic and all management care topics because I know that they can be a little intimidating. Any questions? I'm trying to scroll through and see. Acute is always more critical and unstable than chronic, correct? Yes, Noah. You always want to address acute issues because they're going to pose the most immediate risk to our client. So typically, when it's an acute issue, it's almost always going to take priority over a chronic issue. And once again, Noah, check out our prioritization webinar from a couple weeks ago because we discussed kind of like the prioritization techniques and which client to see first in that. So that should help you a lot with that. You're welcome. Okay, guys. Well, I'm going to let y'all go enjoy the rest of your summer day. Please, once again, check us out. Do some more delegation practice items because I guarantee you will see delegation on NCLEX. Have a wonderful rest of your day.
So for those of you joining, Amber is in the chat and she's going to be commenting throughout and helping answer questions. Right now, as we wait, we're just talking about when anyone signed up for the NCLEX or where you are living. I'm in Virginia. We have some Texas people, California. Awesome. I love California. I've only been to San Diego, but it was beautiful. And we'll get started in just a couple moments. So we have somebody said that they were taking their NCLEX exam on Friday. So super soon. Anybody else taking it this week? Perfect. So you've met the target in both, done 3. Awesome. Scored all high. You sound like you are ready. We got lots of California here. All right, well, we will get ready to get started. So Amber is in the chat. She's going to be moderating, answering questions. She's one of our boot camp nurses here. She did emergency room nursing for a while before moving into education. I'm Miriam, and I am also one of the nurses here at boot camp. And my specialty area is OB, so bonus points if you like OB. I know a lot of people, it's a love-hate relationship. I'll be taking you through this webinar that we'll do on dosage calculation. How do you all feel about dosage calc? It's scary, right? A little tricky. I'm hoping I can give you some pointers that will give you good steps to kind of work through problems, just some steps to follow. So we will go ahead and get started. And if you have any questions throughout, feel free to drop them in the box for Amber and she will get to all of your questions. Okay, I am Miriam. Like I said, I'd like to officially welcome you to our Next Generation NCLEX on dosage calculation. I know that dosage calc can be super overwhelming. I remember in school, I think we had to take a dosage calc exam before every class once we started our clinical in order to pass meds, and we had to get 100% on it. So can be very stressful. Math is not everyone's favorite. So before we get started, I'd love for you all to join your friends, anybody you're studying with, to join our study group and hopefully join in our webinars so that they can get help from boot camp as well. All right, so we are going to look at some dosage calculation problems. Let me get my pen working here. Okay, So we have two problems that I've pulled from our bootcamp question bank that we'll go through, and we're going to approach both using dimensional analysis and ratio proportion. Everybody might have a different method that works for them. Who here loves some dimensional analysis, or who is more of a ratio proportion person? Do you guys have a preference? I personally am more of a dimensional analysis person, but as long as you find a system that works for you and you can work through it, then you are good. So I'll give you guys some steps to be successful for both. In practice, in clinical, you might be given a picture of medication label or maybe just written orders, and you might even be asked to work backwards to make sure if the amount of medication you drawn up in the syringe matches the order given. So all of these different things can happen in practice all the time. So we should be able to move quickly between units and find the information to determine if we're giving the client, or if the client is receiving the right dose of medication. So these different approaches are going to help us solve dosage calculation. So dimensional analysis is going to be more where we're setting up an equation, we're plugging in numbers to cancel units and solve. Ratio proportion is going to be where we use fractions in order to compare relationships, and we're solving for X. Okay, so first let's look at steps for dimensional analysis. So these are just simple steps that if you follow each time, you should be successful. So first you need to compare what you have. So that's like your med label. Then what do I need? What am I looking for? What's the question asking? So that could be maybe how many tablets, how many milligrams, how many milliliters. Maybe you have a powdered vial in an order that you need to reconstitute the medication and determine how much liquid medication to draw up. Then you're going to set up your equation, just set up that middle so our units cancel. And all of this will make sense. We'll work through these steps when we get to our problems. You'll multiply across and divide, and then round, and of course we're always going to verify and check our work. Okay, so if you prefer ratio proportion or the fraction method where you're solving for X, these are going to be the steps that you need to follow. So here you'll also identify your known and your unknown, your ratio. You're going to set up that proportion, and that's just making a comparison. You'll cross multiply here and then solve, and of course verify. Now there are specific rules that you need to follow for ratio proportion in order for it to work. And until I understood these rules, I couldn't make any sense of ratio proportion. So the first thing is that you want to make sure that your units, the numerator, are the same. So if you have milligrams up in the numerator, they both need to be milligrams. Units in the denominator also have to be the same. If they're not, then that means that you need to convert. And those are the basic rules that you need to follow. Okay, so first I have this little problem that you all probably don't even need to set up. You could probably look at it and give me the answer. But I wanted to do something very simple just to show the steps for dimensional analysis and for ratio proportion before we get into those problems that I pulled from the question bank that are a little bit more complicated. So for this, we have 1 milligram per 1 ml, and our order is for 2 milligrams daily. And then we need to find the milliliters to administer per day. Okay, so first let's look at this doing dimensional analysis. So for dimensional analysis, we are going to put what we have on the left side and what we need or what we're trying to get to solve for on the right side. So I am trying to solve for how many milliliters per day. So I'm going to put that on the right side of my equation. And I check off as I go and plug into dimensional analysis just to make sure I'm not going to accidentally, duplicate plugging anything in. On the left side, I can put what I have. So that's my 1 milligram per 1 ml. So I'm going to put 1 ml on the top and 1 milligram on the bottom. The reason why I do it that way is because I need to keep my milliliters. I don't want them to cancel off. If you put them on the bottom, it would cancel because they are opposite. So I then am going to fill in the middle. So that's here, my 2 milligrams daily. So I need my milligrams to cancel here. So where will I put that? Am I putting that at the top or the bottom? At the top, right? Because I have milligrams and milligrams. So per day. And then my milligrams cancel, and I see that I'm going to be left with milliliters per day, which is exactly what I'm looking for. So we do our multiplication across. So 1 times 2 times 1 is 2, right? And then on our bottom, 1 times 1 times 1. So we are going to give 2 milliliters per day. Okay, so that's dimensional analysis. Now let's look at it with ratio proportion. So as we read this, we can say 1 milligram is equal to 1 ml, right? That's how many milligrams is in 1 ml of volume. So then we know that our 2 milligrams is equal to X mLs. That's what we're trying to solve for. So here we're going to cross multiply. First, we have to check that our units match, right? That was one of our rules. So we see we have milligrams on the top and milliliters on the bottom. We're going to cross multiply here, and we get our 1x equals 2 times 1 is 2. So we see that x equals our 2 mLs. Okay, so hopefully that was really simple and you could kind of follow that. And now we can use these steps to plug into these equations that we have. So here's our first problem. The nurse is caring for a client taking acetaminophen 2,600 milligrams per day in 4 divided doses. The nurse reviews the medication. How many tablets per dose does the nurse expect to administer? And it says to record our answer using a whole number. So these dosage questions are considered standalone fill-in-the-blank questions that you would see in our bank and on the NCLEX. So when we look at this, we see that to the right of our answer is going to show us what we're trying to solve for. It's also being asked up here, but we are trying to solve for tablets. So we look at that, and then the next step we're going to do is kind of decide what is a given, what are our given units, and what do we have. So let's look at that. So what do I have? I have this label, and it's going to tell me what I'm holding in my hand. So I'm holding this acetaminophen, and it's 325 milligrams per tablet. So in one tablet, I have 325 milligrams. Now, what are some things that I'm given? I see that my ordered dose is this 2,600 milligrams per day, right? And then my number of doses. What's my number of doses here? 4, right? So I'm giving 2,600 milligrams spread out over 4 times a day. So our next step we're gonna do is what do I need? So what are we looking for? And remember, that's to the right of that answer blank. It's gonna be, we are trying to figure out how many tabs per dose we're gonna be giving to this client. Okay, so to set up the equation, we can take something we know, like the ordered dose, so 2,600 milligrams a day, and I put that on the left side of my equation. And then on the right side, I'm trying to get tabs per dose. So now we can set up the middle. So remember, I said that as I go, I check things off. That's just kind of a helpful tip that I use just to make sure I'm not duplicating anything. So I'm checking those off. I've already entered them. Now I can take any of my other given units and plug them in. So we're trying to get tablets per dose, and right now I have milligrams per day. So I can go to this next one, 4 doses per day, and I can plug that in. Now I need my days to cancel, right? So am I gonna put my days on the top or day on the bottom? What do you all think? We're gonna put it on the top, right? So one day we give 4 doses. So here my days are gonna cancel, and I'd be left with milligrams per dose. Not quite what we need, right? We need tablets per dose. So we can take this next piece of information we have, which is this 325 milligrams per tab, and I can plug that in. Okay, so where do I need to put my milligrams here? Am I putting them on the bottom or am I putting them on the top? On the bottom, right? So 325 milligrams per 1 tab. And that's gonna allow my milligrams to cancel. So I'm gonna be left with tabs per dose when I multiply across the top and the bottom. Okay, so let's do our multiplication. 2,600 times 1, we get 2,600, right? Easiest math we'll do all day. And then at the bottom, 1 times 4 times 325. And what did you guys get? Should have 1,300. Okay, so our next step is gonna be to divide. So what do you get when you do 2,600 divided by 1,300? 2 tabs per dose, right? So the big thing with this is that we need to verify, right? You always want to check your work. So you can work backwards and plug in. The other thing I like to do here is just think, does this make sense? We can give 2 tablets, we could give 2.5 tablets, but if I was given all of a sudden got the answer is 15 tablets, that seems a little weird, right? I wouldn't necessarily give a patient 15 tablets. So you can look at that. You can also look at, did I get a weird decimal, like 2.3? Here we just have a whole number, and if you remember our rounding, it said just to give a whole number, and that's exactly what we have. So let's check our answer, and we see that we're correct. Okay, so we're going to take this same problem and we're going to work it using the ratio proportion method. So since we've already worked this problem, we know already our knowns and our unknowns, but a helpful thing to do with ratio proportion is to plan your steps. So I know that if I have my milligrams per day, I can then take that information and get to milligrams per dose because I have my 4 divided doses. And then next I can get to tabs per dose. And this just helps me keep organized as I go. So I can go step by step. So we need to set up the first proportion, and we know that 2,600 milligrams is in 4, we're giving over 4 doses, right? Those 4 divided doses. And then we want to figure out how many milligrams, so X milligrams per 1 dose. Does that make sense? We need to make sure that we are checking that our units match, and they do here, right? We have milligrams on the top, we have doses on the bottom. So remember, if they didn't match, we would need to do some conversion, but they do. So now we can go to our next slide and cross multiply. Okay, so you take your 2,600 times your 1, so we get 2,600, and our X times 4 equals 4X. And then what do we have to do? We need to get X alone, right? So we're gonna take each side and divide by 4. So what do we get here? 2,600 divided by 4. X equals 650 milligrams, right? So now we've figured out, we took our milligrams per day, we got our milligrams per dose, but now we need to do our last step and get that to tabs per dose. So we need to set up another proportion. So we take that 650 milligrams and we write that 650 milligrams, and we need to know how many tabs to give. So how are we going to set that up? We're going to put 650 milligrams over X tabs, because that's what we're trying to figure out, is that relationship, equals 3. We can take this information because that's what we know are 325 milligrams per 1 tablet. All right, so we're going to verify here that our units match. We have milligrams on the top, tabs on the bottom, and now we can cross multiply. So when we cross multiply here, we're going to take our 650 times our 1, and we get 650, and then we get our 325 times our X, and then we have to get X alone, right? So we're going to divide by 325, and we get X equals, what'd you get? 2 tabs, right? Everybody agrees? Of course, we're going to verify again. I know we already got to this answer. So we know that this is at a whole number. That was what it was asking us to give in the nearest whole number. And we see that we're correct. Okay, so let's look at one other problem here using dimensional analysis and ratio proportion. This one is going to be a little bit more challenging because we have a conversion to do. Okay, so we are going to go from pounds to kilograms. So these can be a little trickier, but I know you all are ready for it. So let's read this problem. The pediatric clinic nurse is reviewing the medication for a 2-year-old client presenting with acute otitis media. The nurse has an order to administer amoxicillin, 90 milligrams per kilogram per day, divided into 2 doses. The client weighs 24 pounds. And we are trying to figure out how many milliliters per dose should the nurse administer. And it says we're going to record our answer using 1 decimal place. So we'll keep that in mind for the end when we're verifying and doing our rounding. Okay, so let's first ask ourselves, what do I have? I have this amoxicillin powdered solution or oral suspension, and I have 400 milligrams per 5 mLs. Okay, now we're going to ask ourselves what other information is given to me. I know that this amoxicillin is ordered as 90 milligrams per kilogram per day. I'm giving it in 2 divided doses, and then my client's weight is 24 pounds. Okay, so now let's look at our next step. And we need to say what we need, which we already mentioned was that milliliters per dose, right? Okay, so we can set up this equation, and first we can do that conversion. So we know that we have this 24 pounds, and I just put that over 1, and I'm trying to get to milliliters per dose, and I put that on the right side, and now we can plug in our middle. All right, so first let's do our conversion and get that out of the way. So we have to convert 24 pounds to kilograms. So what is that conversion number? How many pounds are in 1 kilogram? Put 1 kilogram up top, and it's 2.2 pounds, right? So this is gonna allow my pounds to cancel. So I'm left with kilograms here. Of course, that's nowhere near where we need to be, right? We're trying to get all the way to milliliters per dose, but we've at least done this for our conversion. So the next thing we can plug in is any of our given units. So I'm gonna check off these because I've done that. And we have our ordered dose here of 90 milligrams per kilogram per day. So we can plug that in, 90 milligrams at the top, and then at the bottom, you're gonna put kilogram and day. So here I can get my kilograms to cross off, and I'm left with milligrams per day. Not quite where I need to be, right? But we're getting there. I can then take my next given, which is 2 doses per day, and I can plug that in. So am I gonna put days on the top or days on the bottom here? What do you think? I'm gonna put it on the bottom, right? Because I need, oops, sorry. That is incorrect. Put day on the top because I need them to cancel. Down here will be our dose. So we have in 1 day, and we are gonna give 2 doses. And sorry, I know this pen does not write super well on here, but we'll be able to see it better on the next slide. Then we can plug in our last piece of information. So here our days cancel, and we're left with milligrams per dose. So we have dose where we need it. We're gonna take this 5 mLs, and are we putting that on the top or the bottom? We need milligrams to cancel. So where's milligrams gonna go? On the bottom, right? So 400 milligrams, and we put our 5 mLs on top. So here we have everything is canceled except for milliliters per dose, and that's exactly what we need. All right, so let's look at this, a little better writing to see, and do our multiplication across the top and the bottom. So 24 times 1 times 90 times 1 times 5. What did you guys get? It's gonna be a big number. 10,800, right? All right, we're gonna do the same thing at the bottom. We're gonna multiply across. So 1 times 2.2 times 1 times 2 times 400. And what did you get? 1760. All right, perfect. So now we can divide. So you take your 10,800 divided by 1760, and what did you guys get? 6.1363, something like that, right? So what did we need to do here? We have to verify this, which means that's part of our rounding. So what are we supposed to round to? It was 1 decimal place, right? So you're gonna look to the right of that first decimal place, and we see a 3 there. So since it's less than 5, we're gonna round down, which means we're just gonna drop all of this. So it would be 6.1. If it's 5 or above, then we round up. So if it had been 6.15, then we would have rounded to 6.2. But here it's a 3, so we're gonna drop all of that, and we have 6.1. Do we all agree? Does that sound good? We can plug numbers in. We verify that we've gotten it down to exactly what it was asking, which is 1 decimal place. We can check our answer, and we see that we're correct. Okay, so let's take this now into the ratio proportion method. So we already, of course, know our knowns and unknowns here, but we can plan our steps out. So we can take our pounds, and we can go to what? Kilograms, right? And then we can take that information and we can go to our milligrams per day. And then we can go to milligrams per dose. And then finally to milliliters per dose. So a lot of proportions are going to be set up here. We're going to be bouncing back between step 2 and 3 here and just keep repeating until we get to our desired units, which is milliliters per dose. So our first proportion for this problem that we can set up is going to be converting the weight, just like we did for the other problem. So we know that the child weighs 24 pounds. So we're going to use that to set up the conversion. We're going to put 24 pounds over X kilogram, right? Because we're trying to find out that relationship. We want to know how many kilograms is 24 pounds. And then our conversion here, we're going to take our 2.2 pounds over 1 kilogram, right? We see that our units match. We have pounds up top, kilograms down in the denominator. And then we can go to our next step and cross multiply. So when we cross multiply here, we do our 24 times our 1, and we get 2.2x on the other side. So we have to get x alone, so we're going to divide by 2.2. And what did you get? X equals how many kilograms? 10.9, yes? Great. Okay, so we have our 10.9 kilograms. We've gone from pounds to kilograms, and now we can work on our next step, which is this milligrams per day. Okay, so now that we have this conversion, we can set up our next proportion. Now that we know the weight. So we want to find out the relationship between kilograms and milligrams here. So we're going to put X milligrams, that's our unknown, right, over 10.9 kilograms. Because we're trying to find out that relationship. And then our known is 90 milligrams over kilogram. Okay, so now we can do, this is set up, and we can do our cross multiplication. We see our units match. All right, so we do our X times 1, so 1X, and then we have our 10.9 times our 90. So what did you get here? X equals, what's 10.9 times 90? 981 milligrams. Okay, perfect. So now we know how many milligrams we're giving per day, and we can move on to find out how many milligrams we're gonna give in each dose. Okay, so 981 milligrams is telling us that's the dose in 1 day. But what we give this in 2 divided doses. So we're going to set this up as 981 milligrams, and that is in 2 divided doses. So that's going to be our related fact there. And then, 2 doses. Let me finish writing. And then we need to find out what is X? What are we going to put X with? X milligrams in 1 dose, right? That's what we're trying to solve for. So we see our milligrams match on the top, and we have dose on the bottom, and we can go cross multiply. So you have your 981 times your 1, and then we have our X times our 2, 2X. Okay, so we have to divide by 2 to get X alone, right? So we have 981 equals 2X. We're gonna divide by 2. And what did you get here? X equals how many milligrams? 490.5. Great. All right, so we are so close. We have one more proportion to do. We have our milligrams per dose, and now we need to get to milliliters per dose. So now that we know that, what's going to be our next part that we set up? We need to take our 490.5 milligrams, and we're going to put that over X mLs, because that's the relationship we're trying to find out, is how many mLs that's going to equal. And then our known is going to be this 400 milligrams per 5 mLs, right? Per 5 mLs. Okay, so we see that our units are matching in the numerator and the denominator, and now we can cross multiply. So we're going to take our 490.5 times 5 equals our 400x. So what's 490.5 times 5? We get 2,452.5 equals our 400x. Okay, and then we have to divide by 400, right? Because we have to get x alone. And what did you guys get? We get the same thing, the 6.131. Perfect. So you're going to take that same thing, right? You're gonna look to the right of that decimal place and see that it's a 3, so we're gonna drop that and be left with 6.1 mLs. Of course, to verify, you can, again, plug that X back in throughout and work backwards and see that all your math is correct. This is definitely a lot of steps. So whenever you get these conversions, and it's easy when there's conversions. I know in nursing school, even still now, I have to think, is it 2.2 pounds in a kilogram or the opposite? So you can easily mess up a conversion. So just going back and making sure that everything is put in exactly how it should. Okay, we see that we're correct. So I hope that this has been really helpful and made you a little bit more confident with your dosage calculation questions. I know how challenging they can be and stressful. Here's where you guys can find us if you have more questions or want to see more questions like this. We have a huge question bank that has everything you need to prepare for the NCLEX, and you can go to bootcamp.com/NCLEX and use that question bank. You can see our case study video, walkthroughs, case studies, all our practice questions. If you go under pharmacology section, you'll find more dosage calculation questions like this that have detailed explanations that also include the ratio proportion as well as dimensional analysis for whichever method you prefer. And then here are all our social links so you guys can keep up with everything going on here at Bootcamp. And Amber will be dropping this, if she hasn't already, into the comments for you guys. Keep a lookout on Facebook for our other webinars that will be upcoming. We know that you guys have given great feedback about them and love them, and we are loving doing them for you. So we have a few moments. If you have any additional questions, you can drop them in the chat. Can you use the 25% for renewal? What do you mean by renewal? Like to continue for the next few months? If that's the case, I'm not positive. You can reach out. I would think so, but you can reach out to our support team on the website, and they'll be happy to help you with that. Yes, so just reach out. There's a chat on the NCLEX Bootcamp page, and they will assist you with that and any account questions. You're welcome. I'm so glad that you guys could join us. And this will be posted on Facebook, like it'll stay up there. So you all are welcome to look back and review it for more practice, or if you need to slow it down and rewatch it. You're welcome. You do get a calculator on the exam. It's, and same thing on our website. It's up at the top, so it's on the screen. Oh, good. I'm glad it was helpful. You're welcome. All right, well, if you all don't have any other questions, it was great to see you all and be with you here today, and I hope to see you guys next time. All right, so I would love to officially welcome you guys to our NCLEX Bowtie webinar. We are so excited to have you all here. Like I said, Amber's in the chat. She was an emergency room nurse for several years and then has transitioned into education, and she'll be helping moderate the chat. I'm Miriam, and I'm one of the nurses here at Bootcamp. I work with our other fabulous nurses to create cases, questions, and our video walkthroughs for you all. I've been a nurse for 15 years, and as a new nurse, I worked med-surg and hospice. I loved hospice, but knew med-surg was not going to be the place for me, my permanent home. So I transitioned to the New Life Center, where I've worked ever since. So I'm still in the bedside there. I work in the float pool, and I get to do NICU step down, moms and babies, and go to the deliveries and take care of the babies there, which is my absolute favorite. I love a little adrenaline rush. I know some people love OB, you either love it or you hate it, but that is my home. And then of course, my favorite nursing job is working here at Bootcamp, where I get to work with a fabulous team and help so many students prepare and pass their NCLEX exam. So we've been seeing a lot of feedback about bow ties and how intimidating they can be. And we're here to help you understand them during this webinar. So when you leave here, I want you to feel confident in how to approach this item type when you see it. So if you have any questions as we go, please submit them in the chat, and Amber will be helping to answer all those questions. As we go, I'll also be asking you guys questions just to interact with you throughout the webinar. So feel free to drop your answers and your responses in the chat, and don't leave us hanging. And I will share my slides and we'll get started. Okay. So first, here is what we're going to be covering. So bow tie questions, we're going to go over what a bow tie is, how it's scored, will I have a bow tie question on my exam, and then we're going to get down and do one together and practice. So bow tie questions. Before we go into our bow tie question, I wanted to show you some important information about these Next Gen style questions. So it is testing on clinical judgment, which is really important. The NCLEX measures this clinical judgment, and it's broken down into these 6 steps that you see here. So we have recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. That's a lot, I know, but we're going to get through all these steps. We'll break them up as we approach our question and take it on together. Okay, so parts of a bow tie. So bow tie questions are just standalone items that measure clinical judgment. So we are given our instructions that are always the same, and then we are given scenario and data tabs, and that's going to give us all the information that we need to answer the question about the client to determine what condition they're having, the different actions to take or interventions, and the parameters to monitor. So those were the headers I was just mentioning. So just think of those actions as nursing interventions, our potential condition, which is the disease that they're experiencing, and then the parameters. So what we're going to reassess or evaluate to make sure our interventions are working. You'll be given 4 to 5 answer choices. So in your first column here that you'll tackle first, your conditions, you'll have 4 options to choose from. This is always going to be a potential condition. So you're going to determine based on the information that you're given what the client is experiencing. And then you're going to come over to your actions to take column and determine 2 interventions that you think you should take, and then 2 parameters that you want to monitor. These up here are where you will drag your answers. So you can see that that forms a bow tie, right? So that's where it's getting its name. So you'll drag up your answer responses, and you have to complete all 5 boxes in order to proceed and move forward. If you have wanted to change your mind and already have 2 there, if you just hover over it, it will remove the one that you want. Or of course you can just drag and drop it down below. Okay. So let's go over some questions about if you should see this on your test, how it's scored before we get into strategies and our question that we're going to do together. So these appear on the NCLEX after you've completed 85 questions. They can also appear earlier as a pre-test item. So the NCSBN likes to have 15 pre-test items where you will, they just put out an item to see how it performs. Now, how it's scored. So the good thing here is that you can get partial credit. So you're going to get 1 point for each correct response. Of course, 0 if you have an incorrect response, but you can get a max of 5 points. Okay, so some strategies. I want you guys to take in these strategies and use them as you approach these questions. So you're going to read the scenario and review any data tabs that are given. So here you can see this example. We have health history and vital signs, but you could have data tabs that are diagnostic results, lab results, assessment, progress notes, nurses notes, really anything you can see in the electronic medical record, be fair game. So they'll put those data tabs there and give you this scenario. And as you read it, you need to break it down and determine what each finding is telling you. Is it normal and expected, or is it abnormal and concerning? And just consider that as you go through. And then you're going to go and determine, look at these columns each separately and determine first what potential condition the client is experiencing based on the information. And I want you to approach each of these as a single best item. So, or as its own question. So this first column is your single best, you're picking 1. And then you'll come over to your actions to take next, and you're going to pick 2 actions or interventions to take. And this is like a select N. So the select N is going to be where you pick 2. And then our parameters to monitor, you'll pick 2 also, another select N where we're saying to pick 2. And you'll pick 2 assessment options that you would like to take on for this client to see how your interventions worked. Okay, so let's use that information and go forward and look at this question together. So here's our instructions that you'll see on these questions. Complete the diagram by dragging from the choices below to specify what condition the client is most likely experiencing. 2 actions the nurse should take to address that condition, and 2 parameters the nurse should monitor to assess the client's progress. Now, I want to point out that this says most likely here. So what does that mean if you see most likely? it's going to mean that all of these conditions are possible. So we're given some information about this client that makes it a possible option, but then maybe you're given another piece of information that makes it not as likely. So you're going to use that information to determine which one is most likely occurring. All right, so let's review our health history and our vital sign data tabs. And then after we review them, or as we review them, I want you to think through what is normal and expected versus abnormal and concerning. So a client is 34 weeks pregnant. She's a G3P2 and is being seen in the obstetrician office for a routine prenatal appointment. She reports experiencing mild lower abdominal cramping and a small amount of bright pink vaginal spotting yesterday evening. She also notes recent occasional dyspnea. The client reports a mild headache for the last 2 days and not feeling the baby move very much today. Now looking at our vital signs, we have our temperature is 98.2, we have a pulse of 80, respiratory rate is 20, BP 122/81, we're 97% on room air and have a 2 out of 10 headache. So thinking about that information, we move to our first clinical judgment step here, which is what matters most. And this is where we're looking at that middle column to determine what disease this client is experiencing or what potential condition. So remember I said to look at each finding to determine what's expected and not expected. So do you see anything concerning here? Or hear me say anything concerning as we read this? So I see a few things and we'll go through what do we think about this mild lower abdominal cramping and small amount of bright pink vaginal spotting that we see. So I'm concerned that this could indicate labor. Labor is defined as when we have uterine contractions that are regular and cause dilation and effacement to that cervix, and that's to prepare for delivery. So as that cervix dilates and effaces, it's going to cause some spotting or bleeding, and that's known as bloody show. You may have heard that in school. So I am concerned about the signs of labor and see that she's 34 weeks pregnant, which is preterm. So she shouldn't have a baby. Preterm is anything less than 37 weeks. So keeping that in mind, after that it can be late preterm. We really don't want anyone to deliver until 40 weeks gestation, but before 37 weeks is considered preterm. So what else did you see that was concerning? What about the dyspnea? Is anyone concerned about that? We see dyspnea, but our oxygen saturation looks good. Our respiratory rate is 20, which is on the high end of normal, but that's okay. I see that we have a mild headache being reported. She reports a 2 out of 10 headache. What do you guys think about that? Is that expected in pregnancy, not expected? When you see a headache in pregnancy, what kinds of things do you think about? Maybe you're thinking preeclampsia, right? Well, preeclampsia, which is a hypertensive disorder of pregnancy, we look at the blood pressure, and if the blood pressure is over 140/90, we would be concerned about that. But because it's 122/81, this headache is likely just a normal pregnancy headache. And then what about this last finding that we see is that she has not felt the baby move very much today. Are we concerned about that or not? What do you think? So not feeling the baby move very much, maybe the baby's in a deep sleep state, something definitely to consider. All right, so now we're going to analyze our cues, and that means what could this mean? So what are we most likely experiencing here? So as we go through our answer options, like I said, the most concerning to me was that we have this mild lower abdominal cramping and the vaginal spotting, as well as being 34 weeks pregnant. So I'm concerned about the preterm labor, but let's look at all of our options, of course, to make sure. So placenta previa. What do you know about placenta previa? What makes us consider that this could be placenta previa or maybe not placenta previa? So remember, placenta previa is when that placenta implants low over that cervical opening. And that's going to cause bleeding, right? But the bleeding with placenta previa is painless. So what happens, and yes, this is a stuffed uterus, is the placenta implants low over that cervical opening, and it's either partially or fully covering it. And as that cervical dilation and effacement occurs, it can irritate those vessels and cause bleeding. But remember, it's painless. And this client was reporting some mild cramping, right? So we're not having painless bleeding here. Our next option is this pulmonary embolism. So a pulmonary embolism, we see here, it's a blood clot that appears, and that's going to block that perfusion and blood flow, so we're not able to perfuse the body and oxygenate well. So what do you think about the PE? What's making us think that maybe there's a PE, or what makes you think it's not a PE? We saw that we had the dyspnea, right? So definitely someone with a PE would have some difficulty breathing. But we see that the client is 97% on room air, which is great. So I'm thinking that it's not a PE, but what could cause this? We also have this elevated respiratory rate, but it's the high end of normal. So looking at this image, you'll see that in normal people, not pregnant, when you inhale, your diaphragm is going to contract down, and that's going to allow those lungs to expand. But in pregnancy, that gravid uterus is in the way, and it's pushing up on that diaphragm. So the diaphragm cannot contract down, and the lungs cannot fill with air. So dyspnea late in pregnancy is not concerning. If she was, early in pregnancy, or her oxygen saturation was not so great, we would definitely be concerned. But here I'm thinking that is not the likely cause of the client's symptoms. Okay, and our last option to choose from is an intrauterine fetal demise. So an IUFD is when the fetus dies in utero, and that occurs after 20 weeks gestation. So what are your thoughts on this? Do our findings indicate that there's an IUFD? We see that the baby has not, or she's not felt the baby move much today. So we would have no fetal movement if it was an IUFD. And this patient, maybe she just hasn't felt much movement because the fetus is in a deep sleep state. So keeping all that in mind, remember that we're finding what is most likely happening. So what do we think it is? This is where we prioritize our hypotheses. So where do I start? This is where we're going to make our final decision. What condition is this client experiencing? So we're thinking preterm labor, right? This client's showing us all the signs of this. We have cervical dilation possibly occurring, causing this bloody show to occur, and we have cramping, which could be our uterine contractions. So based on the information that we're given and know, that is most likely the cause. Okay, so now we got to figure out what we're going to do about this. So generating solutions, what can I do? This is where we make a decision for the interventions that we need to perform or prepare to perform. So our nursing process comes into play here, right? We've assessed, diagnosed, now we're going to do our planning and implementation. All right, so remember that the NCLEX is a safety exam. So we need to find actions that are going to keep the client safe in this situation. So if we have preterm labor happening, what kinds of things do we want to do? Maybe assess to determine if this possible condition is the most likely, like rule it in. We want to know, is it preterm labor? Maybe interventions to slow or stop the labor. So we'll keep that in mind as we go through and think of this next question, which is our select N. We're picking 2. So quantify blood loss, QBL, sure, we want to quantify blood loss and keep an eye on that, right? This is possibly correct. However, there hasn't been much blood loss, and it's not going to directly meet our goal of assessing if the client is in labor or slowing or stopping labor. So I'm not thinking that that's an option that I need to do. Assess for uterine contractions. Yeah, right? We want to assess. This is going to help us assess if the labor is occurring. So we can put a monitor, an external monitor on the mom called a TOCO, and that's going to monitor those uterine contractions so we can see the pattern and the frequency, see if she's having regular uterine contractions, if that cramping is in fact uterine contractions. So definitely something that we want to assess. Prepare to administer nifedipine. All right, what do you all know about nifedipine? Some might be saying blood pressure, right? And you're not wrong. But what about in labor? Nifedipine is a tocolytic, which means it's going to slow or stop uterine contractions. That's going to help us prevent this preterm labor or stop it from occurring. So that definitely seems like something we want to do. The next choice here is prepare the client for an abdominal ultrasound. So ultrasounds are going to do things like assess the placental location, maybe assess for an IUFD, check on the fetus, but this is not going to help us assess labor or slow or stop the labor. And our last option here is to prepare the client for a ventilation perfusion scan. So this type of scan is going to assess ventilation and perfusion to the lungs. And there's two parts, right? We have perfusion and oxygenation are two parts for this breathing. So air comes in, and that's our ventilation. And then oxygen has to get to those red blood cells, and that's the perfusion piece. So there's different diseases that can affect how well the body does this. And so helping that can help us understand what disease process a client might be experiencing. So looking at this next slide, this first image is showing us normal. So we see that ventilation, air comes in, and then perfusion with red blood cells with oxygen. This image on the left is showing us issues with ventilation. So anything that prevents air from filling those alveoli and reaching the capillary. So that could be fluid like in pneumonia, and so it's blocking it. Over here on the right side, this image on the right is going to be a problem with perfusion, like when we talk about a pulmonary embolism. So perfusion issues, the PE here, if we're talking about a pulmonary embolism, is blocking blood flow from reaching the capillaries in the lungs, so they're not oxygenated. This client that would have a PE would have no breathing or ventilation issues, but blood flow is stopped, preventing oxygenation of the blood. So this would definitely be assessed if we were worried about breathing this client, the dyspnea, if we were worried about a PE, but it's not going to assess for labor, and it's not going to slow or stop our labor. So take an action. What did we decide? What are we going to do? We are going to prepare to administer nifedipine and assess those uterine contractions, right? And now we get to take on our last step, the sixth step, which is evaluating outcomes. We want to know if what we did, those actions and interventions that we did, if they helped. Okay, so we're taking on this column as another select N where we're going to pick two options. So we might do all of these things as nurses. Many of these you're going to say, well, I would do that. But we want to see what are we reevaluating to determine that our interventions were effective and for this client's condition. So hemoglobin is our first option here. What does hemoglobin tell us? It's going to let us know if we're low on those red blood cells, right? This is great for clients that are having heavy bleeding. We would monitor it with the Previa. Hemoglobin doesn't tell us if we've affected preterm labor process, right? It's not going to give us that information. Respirations. Of course, we're always monitoring a client's respirations, right? But it's not going to tell us anything about this preterm labor. How about cervical dilation? So cervical dilation is what we're monitoring in labor to see if the client's progressing. So we would also be monitoring it if we were trying to stop labor, right? So our cervix here, what happens is as it dilates, think of it as a donut, okay? So the hole in the center of the donut is gonna get wider, and that's cervical dilation. If you flatten that donut and squish it down, that's cervical effacement. So that's the thinning of it. So that process is what's causing bleeding or that bloody show when someone's in labor. So that definitely seems like something we would want to monitor, right? To see if this labor is progressing. Fetal heart tones. So fetal heart tones we monitor with an ultrasound monitor externally, and it's going to bring our fetal heart rate pattern that you see up here, and that's going to help us know if this fetus is tolerating labor, how the fetus is doing during labor. That way we can intervene if we need to, right? So if we saw a concerning fetal heart rate pattern or decelerations, we could give IV fluids, we can give oxygen, we can turn and reposition the mom. So we definitely want to keep an eye on this to see how this fetus is doing during labor. And then our last option here, oxygen saturation. So of course, another important thing to always monitor on clients, but it's not going to tell us about preterm labor progress, which is what we've determined as our answer. So what are we thinking here? Do we all agree? We want to monitor that cervical dilation and that fetal heart rate, right? The fetal heart tones. So remember, this is a safety exam. The 2 parameters we want to monitor are a direct reflection of the interventions we've done. So looking back at our bow tie, we've determined the client has preterm labor. We want to assess for uterine contractions. We want to prepare to give nifedipine or a tocolytic to stop those uterine contractions. And then we want to evaluate the fetal heart tones to see how the fetus is doing in labor and cervical dilation to see if we have slowed and stopped and been effective with a tocolytic to stop the preterm labor. And we see that that's correct. Now, I hope you all feel more prepared to take on bow tie questions. We hope that you all picked up some new strategies and feel confident in approaching these questions. You're gonna do great. So here is where you guys can find us, and Amber will be dropping this in the chat for you all so you have the link. So the top one is where we are on Bootcamp, which you can log on there, and the website has everything you need to prepare and pass for the NCLEX. And the other links are all our social accounts, so we can stay connected with you guys on your nursing journey. We are so glad y'all could join us today, and it was so fun to get to interact with you guys. We have a few moments, so it's left for any questions or comments you all have. Feel free to drop them in the chat. Chris, no, at this time we don't have one-on-one tutor, but we are hoping to do more of these webinars and connect with you all and walk you through different things. The signing up for the chance to win, so the names will be pulled from this, and it'll be announced shortly after in the Facebook group. I'm so glad it was helpful. So the link for the question bank, if you go to bootcamp.com/NCLEX, that'll take you there. And I think Amber put the links there for you if you scroll up in the comments. All right, everyone. Well, I think that is all the time we have for now. Thank you so much for joining, and follow us on all our social accounts and go to the website and take a look around at the question bank and our case studies and everything that we offer.
All right, awesome. Well, it is 1 o'clock, so we'll get started. As you've seen from our title, today we're going to be talking all about how to use Bootcamp to pass the NCLEX. So I'm going to take you over to our live site and show you around what that looks like and how to get the most out of our website and all of the resources that we have to offer. All right, so for those of you who don't know me, my name is Courtney. I'm one of the nurses at NCLEX Bootcamp, and I have been a nurse for 14 years, which is hard to believe. And then for the past 7 of those, I've been a psychiatric nurse practitioner. So Bootcamp has by far been one of my favorite jobs. All of us here really love education. We love helping people pass the NCLEX because we know it can be really, really stressful. So all right. Oh, we've got a couple people who are taking their NCLEX soon. All right, good luck. Okay, so let's dive in. So before I tell you about what Bootcamp is, I want to tell you a little bit about who Bootcamp is. So here we are a team of dedicated nurse educators. We have all come to education from different points in our career because we love education. We're really passionate about it. And we love, like I said, helping people pass the NCLEX because we know it can be a really stressful time. So between all of us, we have many, 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 many years of experience. And I can tell you that we are a bunch of perfectionists. So we have obsessed over every small detail to bring you a study resource that truly looks and feels like the actual NCLEX. So let's kind of dive in here and I will show you around the site and what it looks like. So a lot of times when students first start studying for the NCLEX, they think, oh my gosh, where do I even start? This is so much content. You get those NCLEX study guides and they're like books about this thick and there's so much in there. You think, how do I even get through all of this? But don't worry, we have you covered because if we go over to our site, the first thing that we tell students to start with is our study schedules. So this takes the guesswork out of it for you. So this is what our live site looks like. And if we scroll down on the left-hand side, you'll see that we have some study schedules here for you. And so we have 1 month, 2 month, and 3 month study schedules. And so you can use any of these to line up with whenever you're taking the NCLEX. So say that you're taking the NCLEX in April, which is about a month out, or I'm sorry, May. If you're taking NCLEX in May, that's going to be about a month out. So our 1 month study schedule will probably be a really great fit for you. So if we open this up, we can see what this looks like. And so we have it broken down week by week, day by day, so that you can make sure that you cover everything you need to by the time you go to take the NCLEX. And the really great thing about this is that it breaks it down into nice, manageable chunks so that you don't feel incredibly overwhelmed and you can get through all the content that you need to. So if we take a look at where to start, we first recommend that you start with our Next Generation class, which Dr. Emily leads for us, and you might have met her in one of our webinars before. And then it tells you which case studies to do, it tells you when to take the readiness exams, and then it tells you what questions to answer. So we'll kind of walk through all of these pieces so that you can see where all of these are located. Okay, so like we said, the first thing we tell you to do is take that Next Generation course. And so you can find that under the left-hand panel over here under Review. We have this Next Generation course. And so Dr. Emily has done just a fantastic job of setting this up for you because we know that the Next Generation NCLEX can seem a little daunting because it is somewhat new, and she covers everything you need to know. So she covers the basics of the NCLEX, what to expect, and then talks all about those new Next Generation case studies. So you'll see how to approach a case study. She'll take you through a full-length case study, give you a bunch of tips and tricks about how to approach these and make you feel a lot more comfortable going into answering those questions. All right, and then from there, you'll see on the study schedule, it breaks it down into what standalone questions that you should be answering each day. And so these questions are going to come from our comprehensive test bank, and we have about 1,500 questions in there. And these are going to cover all the topics that you need to know for the NCLEX, and you can customize which questions you want to take on what day, and I'll show you that. So at Bootcamp, one of our biggest mottos is that you should be studying smarter and not harder, right? And so we don't think that you need to answer 10,000 questions to be ready for the NCLEX. We think you need to answer about 1,100 really high quality questions that are going to enhance your learning, like what we have in our test bank. So let me show you what that looks like. Okay, so you can get to our standalone questions from two places. You can either come here on our left-hand panel where it says standalone questions, and you will see those standalone questions are going to be broken down by subject area. So you can make a test plan or create a test of adult health questions, child health, critical care, fundamentals, whatever it is that you're going to be working on that day. The other way that you can get to it is through our Create a Test button. And this is fantastic because you can customize this one to your heart's content. So you can either take it in tutor mode or timed mode, and then you can pick from our question pool. You can use the unused questions or the questions you haven't answered yet, or you can pull from your tagged questions, and I'll show you what that means in just a little bit. You can also create a practice test based on subject. So if you leave all of these checked, you'll get a variety of topics from all the different categories, including case studies. But say we want to focus on pharmacology today. And so say I want to focus on psychopharmacology, just because I'm in mental health, right? So I'm going to uncheck that button right there. I'm going to go over to pharmacology and toggle that down. And so you can split this out if we want to do cardiovascular pharmacology, endocrine, gastro, what have you. And then I'm going to go down and I'm going to check psychiatric pharmacology because that's what we want to focus on today for our studying. But I'm actually going to go up here and click my bookmark questions because I did pull a few specific questions that I want to show you. So if we do that and then we start a test, we can see it's going to pop up with our questions. And the nice thing about our questions is that these look very similar to what you'll see on the actual NCLEX interface. And we've done this because we don't want you to have any surprises on test day. We don't want you to get thrown off by maybe things looking a little bit different. We want you to see something that looks very similar to the NCLEX. So since we're here, we might as well answer this question together. So I'm going to be asking for some audience participation in our chat. So let's take a look at this question. We can answer it and then take a look at what it looks like after we submit it. So we have a nurse who's assessing a client who's diagnosed with major depressive disorder whose dose of fluoxetine was increased yesterday. Which assessment finding is most concerning? So this is kind of a prioritization question, right? So what do you guys know about fluoxetine? What kind of medication is this? Does anybody know? So this is a selective serotonin reuptake inhibitor, right? And so we use these for depression, we use them to treat anxiety. What do we know about common side effects of SSRIs? Okay, I can see people are starting to answer. Yep, it's an SSRI. What are common side effects of SSRIs? Do you know? Sometimes there's a little bit of a delay in the chat. But SSRIs, right, we have those GI side effects, right, are really common. Those sexual side effects are really common. Headaches can be common. Yep. What do we know about how long SSRIs take to start working? They can take a couple weeks, right? So usually we start that dose and we tell people keep taking it even though you don't notice a difference right away. It's going to take a couple weeks to start working. And what do we know about the really the severe side effects, like the dangerous adverse reactions that we might see with antidepressants? Yeah, serotonin syndrome, right? And serotonin syndrome is kind of one of those things that we're always on the lookout for because that could be potentially fatal. Yep, you guys got it. Good job. All right, so knowing that, I think we can probably answer this question, right? So what do you guys think is the answer? We already said nausea and headache were pretty common side effects, right? So are we super concerned about these? Not so much, right? Because we know these are common side effects. But what about low mood? The dose was just increased yesterday, so would we expect this client to be feeling better already? It's probably going to take a while. Now, if this client was saying that they were feeling suicidal, I would definitely be more concerned about this, right? But ongoing low mood, we wouldn't expect that fluoxetine to start working for a couple of weeks anyway, so that's not really unexpected. But what about beads of sweat on the forehead? What could that mean? I see you all are answering. Yeah, everyone likes number 4. What might that mean? What are you thinking? Yeah, that could be a sign of serotonin syndrome, right? So that's pretty concerning. We definitely want to follow up on that, right? So let's see. I think we're probably correct. So if we submit this, this is what it's going to look like for you when you're practicing. We're going to get some information that pops up. So on our left-hand side, we're going to get this box down here. And this is going to give us some really helpful information. So that's going to tell us if we got the answer correct or incorrect. And yes, we got full credit. We got 1 out of 1 points. And then if we go to the right, we're going to see how many people answered this question correctly. So it's going to give you an idea of kind of where you're at in the pack of your peers. And so about 50% of people are answering this question correctly. So congratulations to all of you who got that correct. You're ahead of the curve. That's also going to give you an idea of like how difficult this question is. It's going to tell us our scoring rule if we move a little further to the right. And this is a 0-1 scoring rule on this question because it's a multiple choice question. So we get 0 points for incorrect answers, 1 point for correct answers. And then we get our time spent. And this is really helpful when we're preparing to pace ourselves when we're taking the NCLEX, because we know that the NCLEX, we have 5 hours to take it, and there's a maximum of 150 questions. And so if we do the math, we should be answering taking about 2 minutes per question. So if we got the maximum amount of questions, we could make sure that we finished that exam. So we're kind of aiming for that 2 minute per question average. And then if we go over a little bit further on the right, we're going to get our explanation for this question. And this is kind of where the magic and the learning happens. So you will see that we have our explanation telling us why the correct answer is correct. And of course, like we talked about, we're talking about serotonin syndrome and how we were concerned because sweating is a symptom of serotonin syndrome. So it's going to talk a little bit about that. And the nice thing is we try to embed a lot of images into our explanations because we know that not everybody learns the same way. Some people are more visual learners. And so it can be really helpful to have that visual illustration of the topic that we're talking about. So you can see here we have a nice illustration of kind of what serotonin syndrome might look like. We have all the symptoms kind of illustrated out for us. So we might have that muscle rigidity, we might have the high blood pressure, the tachycardia, the sweating, all of that. And then we have some images embedded throughout our explanation as well. So if we click on those, we can see kind of a nice depiction of how selective serotonin reuptake inhibitors work. So if you want a visual of that. And if we go down, we can see that this is our correct answer explanation. We talk about why it's correct. And then we also have a lot of learning built into our incorrect answer options. So these are going to tell us why those answers are incorrect and why people might have chosen them, right? Or what might have tripped you up. And then if we go all the way to the bottom, we have this nice key takeaway section. And this is a really great piece to focus on because this focuses on what is the key concept that you should learn from this question. Because of course we can't predict exactly what questions you're going to get on the NCLEX, but we can kind of predict themes, right? So if you're being asked about safety in SSRIs, chances are they're going to be asking you about serotonin syndrome. So we're talking about these are all the symptoms that might indicate serotonin syndrome. We want to be on the lookout for that with our SSRIs. And that way, if you get a question on the NCLEX about serotonin syndrome, you'll be able to answer it because you understand this concept, even though it's not the exact same practice question that you got. All right, and if we go down even further, there's a few more resources I want to point out to you. So we have our Ask Bootcamp AI feature. And so this is where you can type in some questions about why is this answer incorrect, or ask it to tell you a little bit more about a certain topic, and that will generate your response if you're looking for a little bit more information. And if that's not enough and you still have questions, you can come down to the very bottom and you can contact our team. So if you click on this, it's going to pop up a chat box for you, and it's going to tag the question that you're asking about, and you can send a message to one of us. And so this is going to be answered by an actual nurse, and you'll get a response back in a couple of hours. So we love feedback, or if you have questions about the question that you answered, we'd love to hear from you. So don't be afraid to take advantage of that. Okay, so that kind of sums up our question bank. So once we were to do these questions, we would hit end to end our practice test. And that's going to generate us a report. And so I had 2 questions tagged in this one, so I got 50% right, so that's, I guess, okay. But it's going to generate you a report, so chances are you're going to be generating a practice test with more than just 2 questions in it, and it's going to tell you how well you did overall, and it's going to tell you how well you did in comparison to everyone else who's taken those questions. So it's going to kind of let you know where you are in the pack. You'll get a nice little note from Dr. Emily talking about how you can improve your test taking. And then it's going to give you a subject breakdown. So if you were generating a practice test that covered a lot of different topics, it's going to tell you areas that you did really well in and maybe some areas that need more attention. All right, so let's go back and take a look at some of our case studies, because we know that the Next Generation NCLEX has case studies, right? And so luckily we have 50 case studies that you can practice with. So there is a lot of them. And so I want to show you what those look like. And so our case studies are going to cover a really wide variety of topics. And so you can get to our case studies from a few different areas. So if we were to go back to our main screen, you can see that they're housed right here under case studies. And so we have case studies in adult health. We have case studies in child health, maternal and OB, mental health, critical care, so all the topics that you might see on the NCLEX. And if we take a look at what those look like, you can see that our case studies are set up to look very similar to the actual NCLEX. And so you're going to see all the different item types that the NCLEX might use. So if we click through, you can see that we're going to have matrix type questions, we have drag and drop questions, we have SATA questions, all to mimic what the NCLEX actually looks like. So let's take a look. I'm going to go back to question 1. So like all the case studies have those 6 questions in them. And so this is a highlight type question. So in this case, we would go through, and I'm just going to randomly pick a few answer options here. And so if we're looking for the 3 findings that are most concerning, so we would pick our answers, and then we would go ahead and submit. And that's going to generate a similar response to what we saw with our standalone questions. So it's going to tell us how many we got correct. So I got 1 correct with my random clicking. And then it's going to tell us that time we spent on the question, right? So we want to aim for that 2 minutes. And then if we scroll down, the thing that our students really say that they love about our case studies is we have these really great video rationale. So you're going to get a video by an actual nurse. It's less than 5 minutes, and it's going to tell you why the correct answers are correct and why the incorrect answers are not correct. And it's going to tell you how to think about this client to get to that, get to those correct answer choices. So this is just like having your favorite professor, your favorite clinical preceptor standing there with you, looking at that client and saying, this is what I'm seeing, this is how I arrived at these correct answers, which is really helpful. And so you can see that we can kind of scrub through here. And in this case, Dr. Emily is telling you all about this case and why those correct answers are correct. And the nice thing is that every single question in all of our case studies is going to have that video walkthrough. And so, like I said, they're less than 5 minutes, so they're short, they're concise, but they really help you understand what you need to know to answer these questions successfully. All right, so the last thing I want to show you is, you probably noticed on our study schedule, is that it was telling you when you should take your readiness exams. And so we have 4 readiness exams available to you on bootcamp.com that are going to help predict for you how likely you are to pass the NCLEX. And so these readiness exams are not just a random compilation of practice questions and case studies. These readiness exams were written specifically based on the NCSBN test plan, which means the content that you're going to see in these readiness exams is going to be very similar to the content that you will see on the actual NCLEX. And by that, I mean that about 18% of questions on this readiness exam are going to be management of care, 14% are going to be physiological adaptation, 12% reduction of risk, and so on and so forth. So the content on the readiness exams closely matches the NCSBN test plan. So that helps us really predict how ready you are to take the exam. So let me show you what that looks like. So you can find our readiness exams over on the corner, or on our left-hand panel under the standalone questions. You'll have our readiness exams. And like I said, there's 4 of those. And so usually we would have you do 1 when you start studying with us, 1 or 2 in the middle, depending on how long you're taking to study for the NCLEX, and then 1 at the end. And so hopefully you should see that prediction go up as to how likely you are to pass. So if we start this exam, you'll see that these are going to look, the questions look the same as our practice questions, and so we would go through, but as we submit each question, this simulates the NCLEX environment. So you're not going to get the pop-up on the right-hand side showing you the explanation for the question. You're just going to go through all 100 questions, and there's 4 case studies embedded throughout each exam, and you're just going to answer questions. And I'm just going to randomly pick some answers here so we can see. But once we got to the end of this exam, we got to question 100, we would submit it. And this is just letting me know that I have some unanswered questions, since I don't think you all want to watch me answer 100 questions. But then we're going to submit our exam. And it's going to generate us a really nice report. And unfortunately, with my random clicking, I have a pretty low chance of passing the NCLEX. But you can see here that you're going to get a score. So it's going to be either low, borderline high, or very high. And it's going to give you a score. So you can see that the average score on this exam is 64%. So you can see if you're scoring above or below the average. And then you're going to get another nice note from Dr. Emily telling you about where you should focus your studies and how to improve this score. And then if we keep scrolling down, you're going to get a subject breakdown. And so this is going to tell you what areas you did really well in, and maybe what areas that need a little bit more attention. So you may have done really well in pharmacology, but management of care, you said, ooh, maybe I need to spend a little bit more time giving some attention to that area. And you can even break that out by specific question of which ones you got correct and which ones you got incorrect. So it really gives you some great data in terms of where you're doing well and where you need to focus a little bit more on. And then you can even scroll down further, and it's going to tell you specifically which questions you got correct and which questions you got incorrect. All right, and then there's just a few more resources I want to show you on our live site. So if we go down, you can see this performance tab is over here on the left-hand side. And so if we click on that, that is also going to give us a really good indication of how ready we are to take the NCLEX. And so you can see it's going to break it out by subject performance as a whole. And so these are based off the standalone questions and the case studies that you do in your from your practice. And so you can see which areas you're doing really well in, and again, which areas might need a little bit more attention. And then if we scroll up to the top, you have these two main targets. And these are also very helpful to take a look at in terms of how ready you are to take the NCLEX. So you can see that for people who have met both targets, they're 99% likely to pass the NCLEX. And so what these mean is this first one is your overall score. So all of the practice questions that you're answering, this is going to give you a percentage of how well you're doing. And so we want to see that average at about 61% or higher. And then this one on the right-hand side is your questions tagged, and that is going to tell us how much of the test bank that you've seen. So the reason we do that is because say you came in and you're like, I love child health, I'm great at child health, I'm answering all the child health questions. And you do that, and maybe your score is like 90% because you just really know your child health. But if you haven't answered all the other questions about like management of care and mental health and critical care, we can't definitively say that you're ready to take the NCLEX because you haven't seen a wide variety of topics. And so that's what this one helps us determine is if you've seen about 1,100 questions in our test bank, we can say that you've seen a good variety of topics, and that should prepare you for whatever questions you might see on the NCLEX. All right. So there's one other thing I want to show you is our tagging system. So if we go back to our questions, we can see, I'm just going to pick our answer here, that we have these tags on the bottom. So we can see these red, yellow, and green tags. And so if you don't click on any of these questions will auto tag. So if we got the answer correct, it's going to tag it as green saying, hey, we know our stuff, we're good to go on this topic. But if I had kind of randomly guessed, like I just happened to click number 4 on this question and I say, oh, I don't really know it that well, I can tag this as either still learning or reviewing. And that is going to tag those questions for me so that when I go back to create a test, I can click on all those questions I'm either reviewing or that I've tagged as still learning that I don't feel that confident in. So it really helps us focus our studies on those areas that maybe we're feeling a little bit weaker on. All right. So, a few additional resources that we have. Of course, we have our Facebook study group, and you all know that because you're in it right now. But we do offer live weekly webinars here. So we have one coming up next week with Dr. Emily talking all about case studies. So that's going to be on April 16th at 3 p.m. Eastern Standard Time. So make sure you register for that and join us. And then last week we had Dr. Amber Adams talking all about delegation. That was a really great webinar as well. It's archived on our Facebook page if you want to go take a look at that. So if you have any friends or any cohort members who are also gearing up to take the NCLEX, make sure that you come down and hit that invite button right here so that they can join as well and join in on our weekly webinars because we don't want anyone to miss out on all the great resources that we have available. So of course you can start studying for free on bootcamp.com. And then if you decide that you want to upgrade to get full access, you can do that. And Emily's going to be dropping those links to get here in the comments. And the good news is that if you're in our webinar today, you will get 25% off your all access pass. And so the code to that is going to be webinar 25, and Emily's going to drop that over there in the comments so that you can take advantage of that and you'll get 25% off that price. All right, so I am going to leave you with a list of links of where you can find us. So make sure that you follow us on social media. We're on Instagram, we're on TikTok, we're on YouTube. Of course, we're on Facebook, which is where we are right now. We really, really love to hear from students. So let us know how the studying is going. Let us know if you have feedback. Of course, let us know when you take the NCLEX and when you pass it, because we love to hear those stories so much. So wherever you are on social media, make sure that you drop in and tell us hi, because we really love to hear from students. So I'm going to hang out for a few minutes if you have any questions. And of course, Emily's in the chat answering all those questions as well. Or if you just want to say hi, that would be great too. So has anybody been using Bootcamp? Let us know how it's going for you. It looks like a couple of people are using it. Gemma is loving Bootcamp. I like it. Awesome. All right. Well, we'll be in the chat. Emily's going to be working on answering all of your questions for you. Like I said, we would love to hear from you. So let us know if you have any questions. And like I said, make sure to join us next week with Dr. Emily on April 16th at 3 p.m. Eastern Standard Time for going over case studies. So she's going to walk you through those case studies and get you feeling really confident with those. So I will see you at our next webinar. All right. Thanks everybody for joining. Take care.